All right, sir, you can start now.
Okay. Good morning and a warm welcome to all the faculty and delegates. Friends, 29th October is a World Stroke Day. We celebrate this day to create awareness about early diagnosis, the importance of timely treatment, and the post-neurological palliative care. For this CME to explain everything about this, we have noted speakers like Dr. Rahul Kulkarni, Dr. Shripat Pujari, and Dr. Lomesh Birud sir. Before starting this session, I have a couple of announcements. IMA Pune every year takes lot many CMEs for its members, as well as it does lots of social work, as well as we are always on a fighting front for our members. And this year too, in the month of November, we are having a annual conference, Multicon 2021. This conference is on a theme that is challenges of COVID-19 in medical practice. We have lot many noted speakers in this conference, and we have 3 orations and 4 awards during this conference. This conference is going to be in a hybrid mode. 200 delegates will be attending physically at IMA Pune Sancheti Hall, and rest of the delegates will be attending online. Friends, this is a last chance to gain MMC points. It has got 6 MMC points, and we all know that we all have to complete our 30 points before February when there is renewal of MMC. So I request you all to attend this conference and complete your 30 points. The second important announcement that I want to make is regarding IMA membership. IMA headquarters has declared 25% concession for IMA membership if you become member in this month. And adding to it, IMA Pune has decided to give free registration for Multicon for those who are becoming IMA members during this month. So please ask your friends to become IMA members. Now I request our President B.L. Deshmukh sir to say a few words.
Namaskar. Very pleasant morning today. I welcome all the listeners and who are watching this program. Dr. Rahul Kulkarni sir, Dr. Pujari sir, Dr. Lomesh Birud sir. Stroke Day is observed on 29th October. I welcome you all for this webinar. Stroke is a medical emergency and prompt treatment is crucial. Every action can reduce brain damage and other complications. Strokes are mainly 2 types, ischemic 85 to 81% and hemorrhagic stroke. Some initial research shows that COVID-19 infection may be possible cause of ischemic stroke, but more study is needed. TIA, sometimes known as a mini stroke. Seek emergency care even if you think TIA is increasing your risk of having a full-blown stroke later. You can avoid risk factors and thereby complication. Every year, more than 7.95 lakh people in USA have a stroke. About 6 lakh, these are first or new stroke. About 1.85 lakhs strokes, nearly 1 of 4 in a people who have had a previous stroke. About 80%, 87% of all strokes are ischemic. With these few words, I stop here and ask Dr. Sunil Ingle to continue proceed.
Thank you, sir. Before starting the first lecture, I would request our IMA AMS chairperson, Dr. Meenakshi Deshpande madam, to address the audience.
Good morning, everybody, and a very good and a healthy morning and a healthy Diwali for all of you. I'm here as an AMS chairperson, and I would like to say a few words about the AMS because everybody should know what is AMS. The AMS means it is the Academy of Medical Specialties. It is a wing of IMA which involves specialty clinicians. It was formed in the year 1979 by the visionaries of Indian Medical Association with the intention of providing a forum for specialists of all branches of medicine to discuss academic matters of multidisciplinary interest. Actually, the main objective is to bring all the recent advances of all specialties for better clinical judgment. That is, we can have focused programs, we can have a detailed focusing on one topic instead of handling many topics in one CME. So that is the main aim of AMS Academy of Medical Specialties. It also motivates specialties to actively participate in the activities of Indian Medical Association because many years back, Indian Medical Association used to be a majority of general practitioners, family physicians, and specialists were less. So we are trying to involve more and more specialists, giving proper clinical guidance to all the multifaceted individuals or doctors of IMA. The headquarters of IMA AMS is in New Delhi, and now it has been shifted permanently to Hyderabad with the effect from 1st April 2008. Currently, there are 18 state chapters and 15,746 member specialists affiliated all over India. 105 fellowships have been conferred. So IMA Pune AMS branch aligns itself to IMA Maharashtra State and Headquarters. And we offer the members the facility to become accredited members. Fellowships degrees are awarded after 2 years of becoming a member of AMS. And many hands-on training workshops are also organized for practical skill development and for training of the students also. All this comes for a very nominal fee of about 1,200 or 1,500, a life membership fee, which you have to fill up your form. The life membership form of AMS is available with the IMA Pune office, or you can even send a mail to imaofpune@gmail.com to get the form and to avail of the registrations. So I appeal to all of you to become members of AMS so that we can have more and more such programs which are focused one specialty, one topic, one programs ahead of us. So thank you. I hand over now to Dr. Sunil Ingre.
Thank you, Meenakshi madam. Now we straightway go to the first lecture. The first lecture is on acute ischemic stroke diagnosis and neuroimaging. The speaker for this lecture is Dr. Rahul Kulkarni. Dr. Rahul Kulkarni doesn't need introduction in Pune city, but to complete the formality, I would introduce him. Dr. Rahul Kulkarni is head neurology department of Janath Mangeshkar Hospital, Pune. He is trained in neurology in Topiwala National Medical College, Mumbai. He is secretary of tropical neurology subsection of Indian Academy of Neurology. He is a member of many international and national neurological associations. He is faculty in many international, national and regional meetings. He has 12 publications and 2 books at his account. He is a principal investigator in more than 25 multi-center trials in neurology. He is actively involved in training practitioners and students. We all know he is a brilliant neurologist right from the student room. His special interest is in CNS infections, neuroimmunology, and neurology education. With this short introduction, I hand it over to Dr. Rahul Kulkarni, sir. Sir, you are not audible.
Thank you.
Yes, sir.
Thank you, Dr. Sunil Ingre. And
Yes,
thank
sir.
you, IMA Pune, to invite us to talk on this topic. Indeed, IMA Pune has been, we have been talking with IMA Pune for a very long period. It is like coming back to home. We have been part of IMA for so many years now. So thank you very much for inviting. Indeed, 29th is going to be a World Stroke Day. And it's important to know about this topic. We have been talking on this topic for years together, but it is worthwhile that everyone should be knowing about this topic because of so many things. So today I'll be talking about the diagnosis and imaging, especially what are the new things which are happening as far as imaging of stroke is concerned. Of course, Dr. Pujari will be talking about thrombolysis, which is an important part of therapy of stroke, and the newer advances of stroke therapy, which is an interventional stroke therapy, which will be talked by Dr. Lomesh Birud afterwards. So I'll be talking about a little bit of basics. It may appear a little boring to some of you, but please bear with me. So I'll be talking about the disease burden of stroke across the globe. What are the clinical features of stroke? What are the differential diagnosis? What are the basic imaging modalities that one should use to arrive at a diagnosis of stroke? And then what are the newer emerging stroke modalities which have been used as far as stroke diagnosis is concerned? I hope my slides have been seen.
Yes, sir. Yes, sir. We are able to see your slides.
Yeah.
Yes, sir.
So, disease burden, stroke indeed is an important disease. We know that it is, as far as world is concerned, in 2017, it was the second leading cause of early death worldwide after cancer. We know that the deaths due to stroke was 55 lakhs per year, and more than 1 billion daily adjusted life years were lost due to stroke. So stroke not just kills a person, but it also makes a person worse. That patient becomes bedridden, or he or she is not able to earn money for his family, and then it causes a lot of disability as far as family is concerned. The incidence of stroke has reduced by 8.1% in last 15 or 20 years. Mainly because of the recent advance of treatment as far as stroke is concerned. But the global prevalence of stroke still remains high. You can see that number of people who suffered from stroke are still very high. More than 8 crore people suffer from stroke. As far as India is concerned, it is the second most leading cause of stroke after cancers in India. But it has got the highest morbidity in the patients. There are many people who suffer stroke. They do not just die, but many of them become not useful. They can't earn money for themselves. WHO says that there are about 1.44 to 1.64 million cases of stroke occurring in India per year. So that's about 14 to 16 lakh of strokes occurring every year. So that would mean that a smaller district place, everyone would suffer stroke in 1 year if you consider the entire country. It comes down that there is one stroke which happens once every 4 seconds. And then one person of stroke dies once every 4 minutes. So the figures look quite horrible. Deshmukh sir told us that ischemic stroke in India would be seen in about 60 to 80%, while hemorrhagic stroke is seen about 20 to 30%. The figures are a little different compared to US, where it is 87% are ischemic stroke. In India, hemorrhagic stroke is a little more compared to ischemic stroke, mainly because of increased hypertension in Indian patient. We will not be talking much about hemorrhagic stroke. We are talking mainly about acute stroke. So what are the features of acute stroke? We know that acute stroke occurs when there is a clot in one of the blood vessels. So basically, we know that acute ischemic stroke occurs when there is a blockade of one of the vessel that would lead to infarct in the distal area, which has been supplied by that artery. There are 5 types of strokes which have been described. One is a large artery thrombus, when there is a clot in the large artery which blocks the artery and the distal area suffers a stroke. There can be a small stroke occurring in what is called as lacunar stroke, when there is a very tiny artery is blocked and then there is a very small stroke. These are the strokes which are common in people who are having diabetes and hypertension. The deficit is not very severe, and then usually the prognosis is usually good in these patients. Third is a cardioembolic stroke, when the stroke starts from heart. There is a clot in the heart, either because of valvular heart disease or atrial fibrillation, or patient who has got cardiomyopathy. He or she may have an thrombus in the heart that gets embolized in the brain, and that leads to cardioembolic stroke. The initial management of these patients is like any other stroke, but eventually they may require different medicines rather than aspirin. These are the patients where we use anticoagulant medicines. Then there are certain strokes which are called as cryptogenic stroke, where we are not sure about what is the cause. The arteries are normal, the heart is normal, but still patient is suffering from stroke. So those strokes are called as cryptogenic strokes. We do a lot of workup in these strokes to find out what is the cause in this patient. In some patients, we do come out with certain rare conditions which can cause strokes. And of course, the fifth cause of stroke is strokes because of other causes like patient who has got a vertebral artery or carotid artery dissection, the strokes which occur because of rare vascular disorders, maybe because of vasculitis. In tubercular meningitis, patient can get stroke. So those are the rare strokes which can occur because of this disease. And then hemorrhagic stroke, of course, occurs when the blood vessel ruptures and then there is a bleeding in the brain. So blood vessel ruptures, typically it ruptures in certain important areas and there is a bleeding in the brain. It can be either intracerebral when the bleeding occurs in the brain or subarachnoid when the bleeding occurs around the brain. We are not talking about much about this stroke. Our today's focus is predominantly going to be on the ischemic stroke. So as far as risk factors are concerned, the classic risk factors for ischemic strokes are hypertension, hyperlipidemia, smoking, diabetes mellitus, physical inactivity, dietary issues, increased waist-hip ratio, increased apolipoprotein, cardiac causes, as I said, alcohol consumption in excess, and increased homocysteine, especially in patients like India. Of course, age, sex, race are the non-modifiable risk factors. So we usually concentrate on these modifiable risk factors. There are certain genetic risk factors which are sometimes modifiable as well as non-modifiable, both in hemorrhagic stroke as well as ischemic stroke. In hemorrhagic stroke, the most common cause is going to be hypertension. The second most and third most cause again is going to be hypertension. So it is hypertension which usually would cause a hemorrhagic stroke. Rarely there can be other things like smoking, diet, alcohol consumption, and obesity. But the most important cause here is hypertension. While in ischemic stroke, there are multiple causes. And of course, there are non-modifiable risk factors and modifiable risk factors in any type of stroke. As far as clinical features of strokes are concerned, hemiparesis, weakness of one hand and one leg, it may be hemiparesis or it can be hemiplegia, gaze palsy, the eyes turning to one side, hemianopia, patient is not seeing in one area, or he is neglecting one area, aphasia where he or she has speech problem, and ataxia when the patient is imbalanced, usually be features of stroke. If the patient has stroke involving brainstem, he or she may have nausea, vomiting, diplopia, gaze palsy, dysarthria, dysphagia, hemiparesis. Sometimes there may be issues with respiration and altered or loss of consciousness. These may be the features of brainstem stroke. If the patient has stroke, which is hemorrhagic stroke, then there may be additional headache. Because of the hemorrhage, there can be headache, there can be vomiting. Patient can have neck pain or neck stiffness. Patient can have light intolerance or photophobia. There can be, of course, nausea, vomiting. Consciousness may be lost in some of these patients. So these usually are the features of strokes. Clinical features, we all know about them. The common symptoms, 5 key types of strokes, the common features. If the stroke involves the left brain, then the classic features of this left brain stroke is left gaze preference, that is the right gaze palsy. Patient has right hemiplegia, patient has deficit in the right field, and then he may be having sensory loss on the right side. If the stroke involves non-dominant of the right hemisphere, patient may have right gaze preference, so he looks on right side, he will have left hemiplegia. There is visual field defect on the left side, and then there is sometimes neglect. If the stroke involves brainstem, then we know that patient will have nausea, vomiting, tinnitus, vertigo, abnormal respiration, diplopia, gaze palsy. I talked about the dysarthria, hemiparesis, decreased consciousness. And then if it involves cerebellum, then patient will have ataxia, and there sometimes can be neck stiffness. And if there is hemorrhage, of course, we know that there is headache, neck pain, and other features that are described. So these are the usual features of different types of or different areas where the patient suffers from stroke. Usually, this is a common question which is asked: can we differentiate between intracerebral hemorrhage and ischemic stroke on clinical basis? There are certain clues which help us to differentiate between these two. Someone who comes with a very high BP at the time of stroke, if the BP is around 250 by 150, 240 by 140, these are the very high BPs where we know that it is likely that the stroke may be hemorrhagic stroke. Headache and vomiting at onset, patient has neck stiffness, he or she may having fits or seizures or loss of consciousness. These features usually would favor that patient has got hemorrhage. While if the patient has got history of TI, he or she had 2 episodes of TI before developing stroke, the cholesterol is very high, or if the patient comes with a stroke which has developed in sleep, what we call as wake-up stroke. So these would make ischemic stroke more likely. There were various scales which were used to differentiate between hemorrhagic stroke and ischemic stroke in the past, but we know that these scales are useless. It is ultimately the imaging which helps us to differentiate between ischemic strokes and hemorrhagic stroke. So how do you differentiate between ischemic stroke and hemorrhagic stroke? The answer is based on the imaging, the CT scan or MRI, full stop. So we usually look at imaging to differentiate between hemorrhage and ischemic stroke. Many experts have failed to differentiate between these two clinically. Many times clinically we think that patient has got hemorrhage and it turns out to be ischemic stroke and vice versa. It is not very often that this happens, but it can happen at sometimes, and then your treatment decision may change. So you must decide whether the patient has suffered an ischemic stroke or hemorrhagic stroke solely based on imaging, not just on the basis of clinical judgment. And there are various differential diagnoses of stroke. I'll be talking about some of these. The most important is TI, about which I'll be talking a little later. Hypoglycemia sometimes can mimic stroke. So patient who has got very low sugar, he or she can present not just with unconsciousness or confusion, but sometimes there can be hemiparesis also. After a convulsion or a seizure, patient can get weakness on the one side, which is called as post-ictal torts paresis. And sometimes it is difficult to differentiate whether patient has suffered a seizure and stroke, or whether it is just a post-ictal weakness that patient has suffered. Migraine, we know, presents with headache, vomiting, photophobia, but some migraineurs can get features where patient can have weakness on one side, they may have difficulty in thinking, they may have talking problem, they may have vision problem, and sometimes, especially younger people, migraine sometimes can mimic like stroke. Hyperglycemia, very, very high sugar can also present sometimes with weakness on one side. They can have funny movement disorders. Hyperglycemia is an important differential diagnosis of sugar, of stroke. Demyelination disorders like multiple sclerosis sometimes can mimic stroke, though it may not present as acutely as stroke, but in younger patient, we always think of demyelination as one of the differential diagnoses. Functional disorder like convergent disorder can mimic stroke. So some patients, especially young female, can present with hemiplegia. One should make sure that it is not functional disorder. And then sometimes central nervous system infections and certain other disorders like metabolic encephalopathy rarely can mimic stroke. And one important differential diagnosis is neck femur fracture, which is often not mentioned as a differential diagnosis in textbook, but we have seen that old person who falls down and then he's not able to move the leg. It is thought that he or she has suffered stroke because the old person the poor person is not able to speak also. So we are not sure whether there is a fracture neck femur. So many times it is been thought that patient has suffered stroke and actually he or she has neck femur fracture. So this is an important differential diagnosis of stroke. So as far as stroke mimics are concerned, as I said, if the patient has got loss of consciousness or seizure activity, then one should think of seizure as an important differential diagnosis. If the patient has got headache at onset or he is getting similar events in the past, then one must think of migraine. If the patient has got infection, the infection can be triggered because of an acute illness, the previous deficit. If the patient has suffered a stroke and he or she gets an infection, the stroke actually transiently can worsen. So systemic infection may look as a differential diagnosis of a stroke mimic, especially in person who has suffered a previous stroke where the weakness worsens. And then certain infections, certain metabolic factors, as I said, like glucose or alcohol consumption can sometimes mimic stroke. So these are the important differential diagnosis. And of course, a fluctuating clinical picture, symptoms which are not classic, history of mental illness sometimes can be seen in people who are having convergent disorder or somatoform disorder. Few slides about TIA. TIA is transient ischemic attack. Usually it should recover completely. So TIA is a diagnosis on the basis of history, not on the basis of examination. So if you examine a patient within 10 minutes and patient has got weakness, one should consider this is stroke. If the patient improves and then he comes to you, says that I had an event, then you should diagnose this as a TIA. TIA initial diagnosis was earlier, the diagnostic criteria said 24 hours. Now we know that the diagnosis is done within 1 hour. So if the deficit improves within 1 hour completely, then it should be considered as TIA. Usually not 1 hour. Usually most of them would improve in few minutes, 2 minutes, 5 minutes, 10 minutes. Often the symptom is neglected by patient as well as sometimes doctors. Patient says that I had weakness of hand. There was some tingling on face. I just rubbed my face. I slept for some time. I drank some glucose solution and then I improved. Then it is often neglected, thinking that it was just weakness, acidity, hypoglycemia, sleep problem, fatigue, etc. But remember that TIA is an important precursor for stroke. If you diagnose them early and treat them early, you can prevent the stroke. The symptoms of TIA are usually hemiparesis, so they never get hemiplegia. They never become grade 0. They have some weakness which lasts for some period, improves. Sometimes there can be vision loss in one eye, which is often missed by patient. They rub the eye, they splash the eye with the water and they improve and they think that it is their rubbing that has improved the vision, but it is actually the spontaneous improvement that occurs in the eye, which is called as a phenomenon called as emeresis fugax. Sometimes there can be sensory symptom that patient tingling in the hand as well as on the face and sometimes on the leg, etc. Isolated unconsciousness, isolated vertigo or unconsciousness are usually not seen in TI. So TI would usually present with weakness, sensory loss and vision loss is the most important factors. They have very high risk of stroke in near future. And can we assess the risk? Can we decide which TIs are going to develop stroke in future and how early? There is a simple scale that we use, and the scale is called as ABCD2, where we look at age of the patient, we look at blood pressure of the patient, we see whether patient had got symptoms which were involving only speech or speech with weakness, we see the duration, we see the diabetes, and we see these factors and then give the score. The score is from 0 to 7. The scale is very simple. It can be used by anyone. It is called as ABCD2 score. And depending on that, we know what is the risk of stroke. If the score is between 0 to 3, then the risk of stroke in first 7 days is 1.2%. If the score is between 4 and 5, then the risk is 5.9. And if the score is 6 to 7, the risk goes to 12. So the risk almost increases 10 times from 0 to 6 to 7. And depending on the score, we decide what action we are going to take. If the patient comes with high score, it is worthwhile admitting this patient because he has got very high risk of stroke in even first 2 days, 8.2%. While in low to moderate, we can evaluate the patient early. So remember that TI is an important disease. Often it is seen by practitioners. One shouldn't miss it. You should immediately investigate these patients. All TI should be investigated in first 24 hours and should be treated in first 24 hours because one can prevent severe strokes in the later day. Now talking about the evaluation, how do we evaluate the stroke patient? Well, of course, we know that strokes earlier were given various types of names, various evaluation, but now it has changed because we know that the average volume of stroke roughly is 26 ml. Average duration of stroke evolution is 10 hours. So stroke can actually evaluate for a period of 10 hours. Though it is acute, it can evaluate sometimes. And following stroke, 4 million neurons, 12 million brain cells, and 15 billion synapses die per minute. And if you don't treat stroke for 1 hour, the brain loses 8 years of his life. So stroke is diagnosed and the patient is not treated for 2 years, 2 hours, he will lose 16 years of his life. So if he was destined to die at the age of 80 years, patient would die at the age of 64 years. So you must try and diagnose stroke early and treat it early. The more time that you save, you can save the brain tissue of the patient. So that is called as time is brain. The earlier you treat, you can save brain tissue in the patient. So in stroke, now the treatment has totally changed. We look at whether he or she is a candidate for thrombolysis and we start the treatment as early as possible. So how to act? Once you diagnose the patient who has suffered stroke, first evaluate the patient, examination is done, and examination done with this scale which is called a NIHS. I'll be talking about this. One should investigate the patient immediately, about which of course I'll be talking, and then see whether he or she is a candidate for thrombolysis. There are inclusion and exclusion criteria about which I'm sure Dr. Pujari will be talking. And if the patient is eligible, one should start treatment with thrombolysis in the patient. So this is how we manage any stroke. See the patient immediately and see whether he is a candidate for thrombolysis. If yes, investigate rapidly and then start the treatment. This is how we usually act in a stroke patient nowadays. So examination, as I said, we examine the patient saying that patient has got left hemiplegia, right hemiplegia, he has got gauge palsy, he has got facial weakness, he has got sensory loss. This can be measured on a scale, and the scale is called as NIHS. It is National Institute of Health Stroke Scale. On the basis of the scale, we can decide what is the stroke score, and we can actually decide the severity of the stroke. So rather than saying the patient had presented with hemiparesis, his power was grade 3, and now he has developed a weakness which is gone to grade 0, we can actually use the scale to decide what is the severity of the stroke. And then the score starts from 0, it can go as high as more than 30. And important is it is available on many various smartphone applications. We know that we use smartphone for many applications, and this score can be measured on the basis of this scale, which can be measured on mobile phones. And there are these 11 criteria which are used, depending on which we decide what is the stroke score. So this is a scale that we use often as far as stroke management is concerned. We use this on smartphone, and then it is very easy. Many residents, many doctors use this when the patient arrives in emergency or when he or she is in hospital. Once the examination is done, of course, investigation should be done immediately. Investigation would include measuring the blood pressure, which is often done by everyone, measuring the sugar of the patient, looking at hemogram and bleeding parameters, and maybe creatinine, especially if the patient is requiring an investigation or a treatment where dye is to be injected, these are the investigation which we do. Of course, imaging is done immediately. Other tests are not usually required immediately. Tests like lipid profile, tests like looking at 2D echo, or tests like doing the homocysteine levels or some rare tests. These are not necessary immediately. They are required for secondary stroke prevention. So they are required for the later stage. These are the tests which are required immediately. Sugar, hemogram, to see whether there is no obvious bleeding issues like platelets are very low or PTINR is deranged, etc. So these are the tests which are done, especially if you're planning to give thrombolytic therapy or you're going to do punctures of the vessels. And creatinine, as I said, if you're going to give dye to the patient, of course, imaging, I'll be talking about imaging in greater length. Talking about sugar, high glucose is often associated with stroke progression. It is associated with increase in the infarct size, and of course, it is associated with poor prognosis. High glucose may be seen in 20 to 50% of the cases of stroke. Some of them may have previous diabetes, some of them may not have diabetes. So it is the stress of stroke that brings on the acute hyperglycemia in the patient. Many of them may have diabetes which is undiagnosed, and later they require long time OHs. And there are patients where HbA1c can be normal. So it is the stress of the stroke that worsens the glucose of the patient. So glucose should be measured, or sugar should be measured in all patients immediately, and we have to treat it aggressively, preferably with insulin. Even if sugar is 250 or 200, we usually make sure that the sugar is lowered when we start treatment in these patients. So we treat sugar very aggressively in these patients, especially in acute setting. As far as imaging is concerned, this is a question which is often asked or always asked, whether to do a CT scan or MRI. There are again going to be advantages and disadvantages of both the tests. The advantages of doing CT scan is that CT scan is fast. It can be done within 2 minutes. It is widely available. So we know that every corner of Pune has CT scan facilities available, and it can diagnose hemorrhage immediately. So diagnosis of hemorrhage is done immediately with the help of CT scan. The disadvantages of CT scan is it does not show acute infarct. So if your patient has suffered an hemiplegia and then you send the patient for CT scan, the CT scan may actually come normal. And then it is difficult for us to explain to the patient as to whether there is on normal, everything is normal on the CT scan, still we are giving the patient treatment. So sometimes it's difficult for us to explain this. And it may not differentiate between a fresh and an old infarct. So if there is a patient who has suffered an old infarct and he suffers additional infarct, we cannot really differentiate on CT scan conclusively whether there is a new infarct or whether this is an old infarct. These are the disadvantages of doing a CT scan. The advantages of MRI is, of course, as I said, MRI can show all types of acute ischemic strokes. So it is very rare that an ischemic stroke would be missed on MRI. This happens rarely, but not very often. I would say more than 90%, more than 95% strokes are seen on MRI. So the stroke mimics, as I said, the earlier few slides back, I told about the stroke mimics. The various abnormalities that mimic stroke can be diagnosed conclusively or confidently on MRI. So patient who has suffered a stroke, patient who suffered a seizure, and then he has a post-tracheal weakness, patient of migraine, patient of demyelination, patient of functional neurological disorder, all these can be differentiated on the basis of MRI. And of course, it gives more information than CT scan. It can tell us many more things as far as the stroke is concerned. The disadvantages of MRI, of course, it is time consuming. It takes at least 20 minutes for an MRI. It is not available freely. Patient has to go from one place to other to go for MRI. Of course, in Pune, it is not a situation. MRI probably is available freely everywhere. But yes, compared to CT scan, the numbers are definitely less. And in claustrophobic patient, those who are not willing to go in the machine, probably we may have to give them sedation, other things. So it may take time, we lose time. We have to treat them early. Remember that we have to diagnose them early and treat them early. So this is one patient where patient had suffered a cerebellar infarct. You see that this is a FLAIR image where we don't see anything. While on diffusion image, we see that there is an infarct in the cerebellum, which is not seen here. So you see that diffusion, which is an acute, shows an infarct, while in FLAIR, which is a subacute, where infarct is not seen. So this patient clearly has suffered a new infarct, which is seen on this diffusion-weighted MRI. So diffusion-weighted MRI has really changed. For last 20 years, we have been using diffusion-weighted MRI, and especially with a newer machine, 3 Tesla and 1.5 Tesla, we can really diagnose even the smaller strokes on the basis of MRI. Remember that this stroke or this infarct will never be seen on CT scan. you do a CT scan after 2 days, 3 days, it may not be seen at all. So it is MRI that really shows us this kind of infarct. Now, as far as CT is concerned, there are various different parameters or different subtle signs that we see on CT to diagnose early infarct. So I'll be talking about certain early signs which we use in CT scan to diagnose infarcts. One of that is called as hyperdense MCA sign. On the plain CT scan, you can see that there is a hyperdense structure here. So this is an artery, middle cerebral artery, in which there is a thrombus, and the thrombus actually can be seen here. So this is a patient where the brain parenchyma may not show anything at all, but there is a hyperdensity in the vessel. So this is called a hyperdense MCA sign. This patient has a thrombus here, which is eventually going to cause, or it has caused a large infarct in this area. This is usually a bad kind of stroke. The second sign that is used is seen as looking at the basal ganglia. We look at the structure of basal ganglia, and some of you can appreciate that in the basal ganglia, we have this caudate, we have this thalamus, we have this putamen, and there is an internal capsule. You can see it normally in this normal side. While in an abnormal side, this structure is not seen. You don't see this classic kind of structure on this side. So this is a very early sign of stroke, which in the experienced eye can diagnose an acute ischemic stroke. Then we can see that on this side, you can see a good sulci and gyri, which are not seen well here. So the sulci are effaced here. You see that probably you are not seeing good sulci gyri here in this area. So this is a sulcal effacement, which is a sign of acute ischemic stroke. And then lastly, there sometimes is a differentiation between gray and white is often missed. You can see that on this side, you see good gray and white. White matter is the one which is near the ventricle or where the fibers grow, while gray matter is an area where we have neurons. The gray matter is there here and the white matter is here. In this area, you don't see the difference between gray and white matter. So patient probably has suffered a fresh infarct in this area. So these are certain signs which are seen on early signs which are seen on CT scan, which are useful for us to differentiate between various types of, to diagnose various types of strokes. What about angiogram? Angiogram can be done immediately with CT scan or MRI. With CT scan, we can give contrast and do a contrast CT angiogram. And with MRI, we can use contrast as well as non-contrast to do a angiogram. Of course, contrast, MR contrast angiogram is better than non-contrast, but we can also go ahead with non-contrast angiogram here. And this helps us to diagnose what is called as LVO, which is a large vessel occlusion, about which Dr. Bhirud will be talking in great detail later. But angiogram is usually helpful for diagnosing the problem in the vessels. Remember that the disease of stroke is not the disease of brain parenchyma, but it is a disease of the blood vessels of the brain. It is not called as cerebral disease, but it's called as cerebrovascular accident. So it is a disease of the vessels of the brain. So we must look at the vessels. So angiogram can be done with CT or MRI when we are sending the patient for CT or MRI. So CT angiogram can be done. It can also show us if there is a plaque here, if there is a calcium deposit here, and you can use colored images to see these images beautifully. You can see angiogram very well with the newer CT scan machines. Of course, we can get great angiograms. And of course, in MRI also, you can get an angiogram. You can see that the vessels are being stenosed here, or there is occlusion. Even with the smaller vessels like anterior cerebral artery or anterior communicating artery, one can see if there is an arterial disease here. And there is an infarct in this ACA territory of the patient. So MR and CT angiogram can also be done when the patient is being subjected for CT scan or MRI respectively. So our policy, our hospital policy, or this is a policy used globally, if the patient comes within window period, effort is made to see if the patient is eligible for thrombolysis and or thrombectomy. These are the actual treatment which are really going to help the patient. So we must do investigations immediately to see whether patient is a candidate for this. So first choice of investigation, doing a CT scan, and with that we do a CT angio. CT scan would rule out a hemorrhage. Sometimes it can show us if there is an infarct, and there is a score which is called as aspect score, which is used on the CT scan to see how big or how large is the stroke. And of course, you can do a CT angiogram to see whether there is a disease of the vessels. If the large vessels are occluded, then the patient can undergo the therapy, which is called as thrombectomy. So this is the first choice of investigation that should be done, CT with CT angiogram. And then MRI is done. We do MRI if the diagnosis is uncertain. So we are not sure whether it is really a stroke. Patient also says that I have got headache. You think that patient may be little functional. So those are the patients where I will do MRI, because MRI would show an infarct, which is often not seen in acute CT scan. So MRI I would do if the diagnosis is uncertain. If the patient presents outside window, then we have time where we know that probably we are not going to offer him thrombolytic therapy or thrombectomy. So those are the patients. So patient says that I have suffered a stroke 2 days back. So those are the patients where I would do MR angiogram, because it would give us definite more information, and it can we can see everything in one go. That is where I would do MR angiogram. And sometimes in large infarcts, where sometimes it is difficult to thrombolize those patients. So patient presents with a very severe deficit. Many times we send the patient for MRI, because if the infarct is large, many times we don't offer this therapy of thrombolysis in these patients because they have very, very high risk of hemorrhage. So these are the only 3 indications where we send the patient for MRI or MR angiogram as a first investigation as far as strokes are concerned. So this is our policy, and this is a policy which is being used everywhere. Now, what about advanced imaging modalities? As the world is advancing, even the stroke investigations are advancing. Of course, the stroke treatment has advanced leaps and bounds. But as far as imaging modalities are concerned, they definitely have changed over the years. So we may require more information to see how much tissue is viable. I'll be talking about what is viable tissue, and to see if there are collaterals, because we know that if the one artery is blocked and if there are no good collaterals supplying that area, even if you open the artery, the brain is not going to improve. But if the patient has got good collaterals and if you open the artery, then the chances of functional recovery is good in those patients. So these collaterals can be seen by doing certain more tests. And of course, we make sure that we investigate to see if there is a viable tissue in this patient. So what is this viable tissue? So once a patient gets a stroke, some area of the brain immediately dies. So this central area, or what is called as core, is an area which immediately dies. This is an area which whatever you do is not going to improve. This is a dead tissue. This is a dead tissue. And this is called as core. Our aim is to reduce the core to the lowest. The area surrounding this core tissue is called as penumbra tissue. This is an area which is become ischemic. It is not yet dead. It is going to die if you don't treat the patient well. So the core, which is initially small, grows in size as the stroke progresses, and the deficit can worsen as the patient can also worsen. So this tissue is ischemic tissue. It is not dead. And if the patient is not treated, the core is going to expand in size. So it is the penumbra tissue, which is a potentially salvageable tissue. And if you treat the patient early by giving thrombolytic therapy or doing the thrombectomy, it is a penumbra tissue that can be saved in the patient. So efforts are made to diagnose this penumbra tissue. There are certain tests which are done to diagnose this penumbra tissue. Whether you can differentiate between core and penumbra, this is done by doing these newer techniques. And these tests or newer techniques are the tests which are done on the basis of perfusion-based images. So as I said, diffusion MRI shows us ischemic area, while perfusion area shows us hypoperfused area. So if the patient has got a mismatch, a diffusion restriction which is smaller than the hypoperfused area, just showing an example. So this is a patient where patient has got a diffusion restriction in this area. So this is a dead tissue which you can see on a ADC map, which is similar to a diffusion weighted image. It appears dark. While if you look at the perfusion area, there is a large area which is hypoperfused. So there is a big area which is about to die. So perfusion tells us total ischemic area, while diffusion tells us the core. It is a difference between diffusion and perfusion that tells us which is a penumbra area here. So here on the imaging, it is not called as penumbra, it is called as mismatch. So the difference between perfusion and diffusion is an area which is called as mismatch. If the mismatch is large, then of course, you know that you treat this patient, the patient is going to improve. And this patient additionally also has occlusion of the blood vessel here. So if you open this artery, you can prevent this stroke, which is smaller, to become this big. So this can be done by certain tests. You can diagnose this mismatch. This can be done by doing this perfusion MRI. This can also be done by doing a test which is called as CT perfusion. So with the help of CT perfusion or MRI perfusion, we can accurately diagnose whether the patient has got an infarct which is small and actually the perfusion defect is large. And if the perfusion defect is large, doing the thrombolytic therapy or the thrombectomy therapy is really going to benefit the patient. So this perfusion-based imaging, if it documents that there is definitely abnormality, we can offer thrombolysis or thrombectomy therapies even beyond the window period. Window period we know is up to 4.5 years. Dr. Pujari will be talking about this. But if you demonstrate that there is a difference, you can even give this therapy for longer period. And especially it is useful for us in wake-up stroke patient. Those patients who sleep at night and they get up in the morning with the deficit. Someone gets up in the morning at 6:30 and then immediately the family member notices that patient has suffered stroke. We don't know whether the stroke has occurred at 11:30, whether it has occurred at 2:30, or whether it is occurred at 6 a.m. or whether it has occurred at 6:30 a.m. So wake-up strokes was always an issue as far as treatment of strokes was concerned. We now know that in the wake-up stroke, if you do this perfusion-based imaging and if you can demonstrate that there is a mismatch, we know that there is certain tissue which can be saved in this wake-up stroke. We use this technique often in this wake-up stroke, the perfusion-based imaging, either CT perfusion or MRI perfusion. And if you demonstrate that there is a mismatch, we can treat this patient with thrombolytic therapy, which was not possible earlier, maybe 3 years back. It is only last 3 to 4 years that we are treating wake-up stroke with the help of thrombolytic therapy because of knowing this fact that there is certain tissue which can be salvaged. And then we move one step ahead. There's a new software which is for CT or MRI. This is called as Rapid software. This is a very new software. It is an application-based software. So now the world is moving towards mobile. It is all mobile. So it is based on a mobile. During the scanning, the software processes images and it measures the mismatch and tells if the patient is eligible for thrombolysis or not. So as the patient is undergoing CT scan or an MRI, it is the artificial intelligence of the Rapid software. It can measure the perfusion abnormality. It can measure the mismatch, and it can tell us whether we can lyse the patient or not. And it is offered at Dinanath Mangeshkar Hospital for the first time in Maharashtra. We have been using it for last 3 years. It has been, of course, now available in many centers now, but this is a really new technique which is used. So you can see that this is a patient, one patient where patient has undergone CT scan. You can see that this is an area which is an infarcted tissue. You can see that the size is 49 ml, and this is a large area which is a perfusion defect, which is 112 ml. So the mismatch is 63 ml. So if you treat this patient, you can save 63 ml of the tissue here, and the mismatch ratio is 2.3. So definitely we know that this is a patient where if you use thrombolysis or thrombectomy, you can save this area. So this is a new technique which have been used, and this can be done at the center, and the images come immediately on our phone, maybe at night, maybe early morning, anytime. So we can see this wherever you are in the bathroom, you are walking, you are traveling, you can see the images and take the decision whether you're going to start thrombolytic therapy or not. And you can see the vessel. You can see the vessel is occluded here. It can tell us that this is an area which is going to be infarcted. So it can also tell us the size of infarct if you don't treat the patient well. This is a new software which is being used. The advantages of this software is fully automated. It comes with CT perfusion analysis. It has potential to improve reliability. It is very reliable and it can be reproduced anytime. It analyzes the perfusion map well. As I said, it has got highest precision and very good accuracy. It is no human is involved. So it is a machine that does everything. The artificial intelligence does everything. So it is a computer who decides everything. Even if the radiologists are not there, the radiology resident is not there, technician just initiates or involves this rapid system, and you can get information immediately. It can give information about the mismatch. It provides us reliable estimate about the salvageable tissue. So it is really a good technique that is being used for last few years by us, and it is really changed the way we manage our stroke patient. It is definitely useful for us. So to summarize, clinical diagnosis of stroke is not at all difficult. Everyone knows how to diagnose stroke. Every physician must have seen stroke patient, but one must be aware of mimics. Make sure that you know what are the mimics and don't miss those mimics when you're diagnosing stroke, because if you treat these mimics with stroke thrombolytic therapies, the things can go haywire. So one must diagnose them properly. Effort must be made to thrombolyze a stroke patient as early as possible. So the first aid therapy for any stroke, people ask what is the first aid therapy for MI? It has been said that giving sublingual sorbitrate or maybe giving aspirin. Remember that the first aid for stroke is sending the patient to a hospital which has got 3 things. It has got CT scan facilities, it has got ICU facility, and it has got thrombolysis facility. Even if there is no neurologist, there are physicians who are doing thrombolysis therapy. So first step to stroke is to go to a hospital which has got these three facilities: CT scan, ICU, and thrombolysis. CT scan usually is an investigation of stroke in a patient of stroke within window. Angio should be performed to see if there is a vessel disease in these patients. And of course, newer perfusion techniques are helping us to expand the use of thrombolytic therapies in certain patients where we had never thought of thrombolizing these patients, especially wake-up stroke or beyond this 4.5 hours. These newer perfusion techniques have really helped the life of some of these patients. I think I'll stop here. Thank you very much.
Thank you, sir. Thank you for a very lucid and informative lecture and very good take-home messages. We'll be taking the questions during the panel discussion, but just one or two questions we will take right now.
Sir,
Dr. Deshmukh wants to ask you a question.
Sir, my question to you, if a patient is in a very remote area where imaging facility is not available, if the treating doctor diagnosed as a stroke, his BP is normal, if he has given aspirin and statin, will it be correct or medical negligence or create any medical legal problem?
See, as I said, the diagnosis of stroke has to be done by doing a CT scan. You can't say that stroke is a clinical diagnosis. Of course, the imaging has to be done because you can't diagnose MI. Patient has got chest pain, he has got sweating, his BP is low, his pulse rate has changed. You would diagnose it by doing an ECG, right? So ECG is a basic test for diagnosis of stroke, test for diagnosis of MI. Similarly, CT scan is a basic diagnostic test for diagnosing stroke. So imaging has to be done for sure. Especially in remote areas, we now know that there are CT scans available even at taluka places. So doing CT scan is not difficult at all nowadays. Secondly, even in patients who have suffered intracerebral hemorrhage, even if you give aspirin, the risk of hemorrhage worsening is not very high. So medico-legally, he is not incorrect, but I would say scientifically, he is not correct. He or patient should undergo CT scan. So rather than keeping the patient in your hospital saying that let us give aspirin and wait for 24 hours, see what happens, I would recommend that even from remote area, there is a CT scan which is available within 50 kilometers everywhere in India nowadays. Patient should undergo CT scan, which will take just 1 or 2 hours travel. So CT scan has to be done minimally for diagnosis and then the treatment should be started.
Thank you. Thank you, sir. Dr. Mantri wants to.
Thank you, Dr. Rahul Kulkarni, sir. Excellent presentation. I want to ask you one thing. What is DSA, that digital subjective angiography, and its role in cerebrovascular diseases?
Yes, so Dr. Lomesh Birud will be talking about DSA in great detail later. But we know that DSA is a test which can tell us or show us the abnormalities of the vessel in a much better way compared to CT angiogram or an MR angiogram. But usually when we start the treatment, we don't do DSA as a first investigation. We do a CT angio or an MR angio. If the CT angio or MR angio shows an arterial occlusion or a vessel occlusion, what is called a large vessel occlusion, then the patient would require DSA. And during DSA, if they think that there is an occlusion, then effort is made to open the artery either by doing thrombectomy. So DSA is indicated after CT or MRI showing an arterial occlusion. Then you do a DSA, where on the same time in the cath lab, the artery can be opened up. That, of course, Dr. Birud will be talking in detail. So that's the first indication of doing a DSA. Second indication of doing a DSA is after the patient has been treated and you think that patient has got a carotid artery stenosis, there is an occlusion or there is a stenosis here. We know now that we have to treat this stenosis either by doing a stenting or doing a surgery with which you can prevent the further strokes. So for secondary stroke prevention, DSA is an investigation which is done to see exactly how bad is an occlusion or how bad is a stenosis so as to do surgery or stenting in those patients. So indication of DSA is after a large vessel occlusion in acute setting, or if you're going to do a revascularization procedure, either a stenting or an endarterectomy at a later stage. So these are two indications of DSA in stroke.
Thank you.
Thank you, sir. Last one question, Dr. Khade wants to ask, what are the clinical signs of neurodeterioration?
So as I said, the signs of neurodeterioration is, of course, the patient worsens. His power initially, which is 4, becomes 0 or becomes 2. He or she may develop newer signs that patient initially had just weakness in the hand, but then it goes in the leg also, or the patient starts becoming drowsy also. So those will be the signs of deterioration. We usually measure it on the basis of this score that I told you as NIHS score. So we know now that patient has come to us with NIHS 7, and then after 2 hours or 3 hours, when the patient is in ICU or wherever he is been seen by a doctor, and then he says that the score has increased to 10 or score has increased to 12. We know now that the stroke is worsening. So we use actually the NIHS to see whether the stroke is worsening or improving. So the scale is very simple. Anyone can use it. The training takes hardly 1 day. Anyone can use this score, but it is a very reliable way of diagnosing and monitoring the strokes. Not just diagnosing, but monitoring also. We use this NIHS score to see the monitoring and see whether the patient is worsening.
Thank you, sir. Thank you very much. Now, I request IMA Pune President Dr. B.N. Deshmukh, sir, to felicitate Dr. Rahul Kulkarni, sir.
Sir, this is bouquet for you.
Thank you. Thank you. Thank you. Thank you.
And this is IMA Uparna for you.
Thank you. Thank you, sir. I have one. I should have carried it when you're talking here now. Next time I'll do that. Virtual lecture se main gadat ghalungas basan pudcha veli. Last time you have given me one. Thank you.
Thank you, sir. Thank you.
Thank you. Thanks a lot.
Thank you, sir. Yes. Thank you, sir.
Thank you.
Now, I request Secretary Dr. Alka Shivsagar Madam to introduce our next speaker.
Yes, good morning all. Just now Dr. Rahul Kulkarni has explained us how the investigations and the diagnosis is made. So now further Dr. Shripat Pujari will tell us about the role of IV thrombolysis in management of stroke. So Dr. Shripat Pujari is a MD, DM, DNB and MRCP London. At present, sir is attached to Dinanath Mangeshkar Hospital and Noble Hospital, Pune. His clinic is in Business Court, Mukundnagar near Swargate. He is trained in neurology at Sir JJ Hospital, Mumbai and received further fellowship and research in London, United Kingdom. His special interest in multiple sclerosis, neuromyelitis optica and neuroinflammatory disorders. He has several publications. He is actively involved in educating resident doctors, physicians, and GPs, as well as in various patient awareness and education programs. Music and drama are his hobbies. So over to Dr. Shripat Pujari, sir.
Thank you very much. IMA Pune, Dr. Shivsagar, Dr. Deshmukh Ingve, and all. Thank you for giving me this opportunity to share my views on the most important disease in neurology, I think, we all think, which is stroke, both in terms of management as well as the recent advances and the developments that have occurred. And after the lucid lecture by Dr. Kulkarni, wherein he has set the stage for, am I audible? Am I well audible?
Yes, sir.
Yes, sir.
So after he has set the stage so well in terms of how to diagnose a stroke and how to use all modalities of scanning such as CT, MRI and their perfusion modalities, I am now going to talk on. So as you can see, there are two major causes of death: heart attack and brain attack. And you can see the devastating damage that the artery occlusion because of ischemic stroke, that is what we call infarct, has made in the left cerebral hemisphere, more than 2/3 of which is appearing black, which is the infarcted area. Brain attack is also known as stroke, paralysis, cerebral infarct or cerebrovascular accident. Is commonly either due to an atherosclerotic clot in one of the major arteries that goes from the heart to the neck, or is because of an embolic event wherein embolus from either the heart or a large artery dislodges and occludes another middle-sized artery within the brain, such as anterior, middle, or posterior cerebral artery. Both are vascular events, thromboembolic. They share the same risk factors. Acute, they have very high mortality and morbidity. They are the first and third most common causes of death. But as a sad thing, stroke receives much less attention as compared to MI. Just to reiterate, many of you may have seen this slide already, but following stroke, 4 million neurons, 12 million brain cells, 15 billion synapses die per minute. In 1 hour, it loses 8 years of its complete lifetime. And remember, average stroke duration evolution may last up to 10 to even up to 24 hours. So imagine the devastating deficit that it will create. We all know injection to dissolve such a clot either in the brain or heart is called thrombolysis. Streptokinase became popular in MI right since in 90s, and there are several versions of thrombolytics with lesser side effects that have got launched and now being marketed. When patient is complaining of chest pain, he is immediately rushed to the hospital to avail this benefit, and it has now gone even up to PAMI, we all know. But the one who suffers from stroke, approach is a bit nihilistic, not that aggressive. Patients are given ecosprin, physiotherapy, and then patients are brought, say, after 6 to even up to 24 hours post-event. A very sad situation. Yes, till mid-90s, there wasn't much we could do. But since mid-90s, there has been a revolution. And like MI or acute coronary syndrome, we have all the same modalities of management equally available for acute ischemic stroke or cerebral infarct. So the same TPA, which is used for MI and pulmonary embolism, its isomer alteplase is also available to bust the clot that gets occluded in the brain. It's called Actilize. The only difference is that the therapeutic time window until recently was much narrower, only 4.5 hours. But remember, it is licensed, FDA approved, and approved by European Medical Agency as well as our Indian DCGI. Dr. Kulkarni just explained us the concept of umbra penumbra. We all know umbra is the dead and penumbra is the alive but dysfunctional tissue. It is the treatment. The treatment is targeted at this area and can be salvaged. A figure similar to Dr. Kulkarni, the central black is the dead area, while the peripheral penumbra is the live but dysfunctional. And look at what will happen if you thrombolize the patient and reperfusion, which means opening the artery and bringing blood supply to this live dysfunctional tissue, offers the potential to reduce extent of ischemic injury. This again, with a scan I have explained, this is a diffusion weighted MRI, which shows more equivalent to the core infarcted or permanently damaged area. But look at the perfusion deficit, perfusion involvement, which is so large. And if we thrombolize, we have reverted back all the under-perfused brain. But if we had not reverted, look at the amount of a black colored brain, that infarcted brain that we are going to leave behind. So with this introduction, I will move on to intravenous alteplase. It's used in acute stroke, and to begin with, its pharmacology and the evidence through which it went before it became licensed. So it's a very simple concept really. It binds to fibrin in the thrombus, converts plasminogen to plasmin, and thus initiates the dissolution of the clot. There is a 60% reduction in circulating fibrinogen levels at 4 hours. There is more than 80% reduction in circulating fibrinogen levels. Fibrinogen is we all know the substance that we can measure in the factor 2, measure in the blood, that really precipitates into fibrin, forms bands and filaments, and those are the ones that bind the platelet and the white and red blood cells to form the clot. So it is this that up to 60 to 80% that is reduced, and 20 and 35% reductions in plasminogen and alpha 2 antiplasmin. These are the ones that actually inhibit or prevent the dissolution of clot, and it is the inhibition or reduction in its level that is also achieved by TPA, that is the altiplase. As all drugs will have, there are certain adverse reactions. Obviously, a drug that will reduce fibrin, fibrinogen, and dissolve the clot will have hemorrhage as a common adverse effect. Intracerebral hemorrhage, as we open the artery, happens to be a common side effect, but not that common and not that deleterious, although it is mentioned as one of the prominent ones. And there can be some mild bleedings in the gum as well as gastrointestinal tract, but never, very rarely that severe to really stop the infusion of altiplase. Immune disorder, we all know there is anaphylaxis, urticaria, and sometimes patients' blood pressure can fall precipitately, but it's a very rare event. Again, in nervous system, intracranial hemorrhage and reperfusion injury can happen rarely. There can be rare pericardial hemorrhage and GI hemorrhage. So, with this, now let us learn which were the pivotal trials, the important trials, which promoted its licensing as thrombolytic all over the world. Right in 1995, NIMS, that is National Institute of Neurological Disorders and Stroke, did a placebo-controlled trial. Placebo means water against altiplase, and it was used up to 6 hours, but it became visible that it was definitely extremely effective within 3 hours. There was a 33%, 1/3 increased likelihood to have minimal or no disability at 90 days. And there was a 6.4 incidence of hemorrhage, but majority were mild, and the incidence of severe or life-threatening hemorrhage was very small, and even that hemorrhage could be reverted with drugs such as FDP or cryoprecipitate. Then in 2002, there appeared another Atlantis study, which was altiplase thrombolysis for acute non-interventional therapy in ischemic stroke, a subset analysis of which up to 3 hours again reiterated that it was effective. There was some increase in incidence of bleed, but better clinical outcome in TPA group. And then in another landmark study called ICAS-3, European Cooperative Acute Stroke Study, which extended its effectiveness up to 4.5 hours with no increased incidence of bleed. Subsequently, a safe implementation of thrombolysis register was maintained with collaboration of 80 countries, 1,600 centers, and more than 2 lakh patients enrolled, and not just on IV thrombolysis, but also in relation to thrombectomy. Then a combination of thrombolysis with thrombectomy, and thrombectomy, Dr. Birud is going to teach you exactly what it incurs. All stroke patients, atrial fibrillation, as well as the other kind of stroke, that is hemorrhagic stroke, all was kept. And with this 6 registry, we had the following outcomes or conclusions. There was one where just monitoring was done in more than 6,000 patients, and it was shown. This is all post-marketing, okay? We also do what we call as post-marketing study or surveillance, and it was found that it was effective and safe within 3 hours. And then an audit was done of this whole registry, again in more than 2,000 pooled patients, and it was found to be effective and safe in 4.5 hours. A subset of non-European patients, because ethnically we are different from Caucasians, we are Asians, and it was found, and more than around 600 patients, it was found that it was effective within 3 hours. An Indian sub-data was maintained, and again it was found to be effective. And then after 3 hours, an upper time window monitoring study was also performed in 4,000 patients, out of which around 1,100 had received it between 3 to 4.5 hours, and it was found to be equally effective. So it's such an effective drug that if there is this concept of number needed to treat, I'm talking of statistical significance, very effective, but how effective it is in reality. For that, a terminology called number needed to treat has been devised, and look how effective it is. If used in less than or equal to 90 minutes, if you 1 out of 4.5 patients is going to get completely better, and some of the others, 1 or 2 is also going to acquire partial deficit, partial benefit. If used within 3 hours, then 1 out of 9 is going to get completely better. And if you used within 4.5 hours, 1 out of 14 is going to get completely better. Remember, the numbers for acute myocardial infarction, even for acute myocardial infarction, are not as good as acute ischemic stroke. There, if you see, it's somewhere between 14 to 28. So the effect in terms of number needed to treat is much better with acute ischemic stroke than even acute myocardial infarction. Even in those who had, what Dr. Kulkarni was saying, a higher NIH, the higher the NIH, and I'm going to tell you what NIH is briefly, the higher the score more than 20 out of 40 means a severe stroke. It was tried in severe strokes as well, and there was no excess in risk of intracerebral hemorrhage, and it was still found to be effective. The original trials that I showed showed that it was effective in patients aged less than 8 years, but it was tried in patients, elderly patients as well, with favorable outcomes. And even in those patients who were on both aspirin and clopidogrel, the outcomes were comparable. That means there was no really serious increased incidence of hemorrhage. There are some contraindications. Obviously, if the time of onset is unclear and there is CT shows an intracranial hemorrhage, prior ischemic stroke, where if the tissue, there is a prior ischemic stroke, then the brain tissue is necrotic, which increases the risk of bleed. Severe head injury, intracranial or spinal surgery, or risk of bleeding. Obviously, if you have a background where there is increased incidence of bleeding, it becomes a contraindication. If there is a coagulation problem, either in the form of low platelets or coagulation blood tests, if patient has received heparin, obviously you can't give, because then it would increase the heparin, or the newer anticoagulants like dabigatran. Obviously, there is an increased risk of bleed. But if the patients have received the newer anticoagulants, there is a clause, if you can revert their effect, you can still give it. And if your patients have received this tirofiban for acute myocardial infarction, and then if patient has had endocarditis or a large tumor like glioma, where the glioma can bleed, then you may not use thrombolysis with alteplase. There is an isomer called tenecteplase, which is a third-generation thrombolytic. It is a genetically engineered variant of RTPA with substitution of 3 amino acid sites. The mechanism is same, with an advantage of 18 minutes slower plasma clearance, so allows for rapid single bolus than an 1 hour infusion, the method of delivery which is used for alteplase. So here you can use it as a bolus. But there are several only small cohort trials done by certain investigators and a meta-analysis, and then an Indian experience which has showed its efficacy, but only in 3 hours. It is, however, not yet US FDA approved. It has been approved by DCGI. We are using it in some patients within 3 hours, but the one that is licensed uniformly for 4.5 hours, and in my later slides, I'm going to show how its use has extended even up to 9 hours, is the drug called alteplase or Actelize. So what is the protocol? Door to needle time is the time period from the time patient arrives at the casualty to the time the patient is administered alteplase. See, within 10 minutes, initial evaluation has to be performed, the stroke team notified, and in 25 minutes, the scan has to be there. In less than 45 minutes, scan and labs have to be interpreted, and the alteplase has to be delivered within 60 minutes. That's the NIH recommended response times. So here, Formula One, when the Formula One car stops, then dozens of people, stops for that servicing thing. Dozens of people pounce upon the car, and nobody knows. We don't understand what they are all doing. Each is checking a wheel, checking a screw or something, but everybody has a set duty here. So like this Formula One stop, emergency department and strokes turn chaos into order. they all have a high degree of suspicion for acute ischemic stroke. They are trained in rapid assessment. The housemen and EMS doctors immediately inform all the concerned specialists. The doctor determines the exact time of event. Urgent CT is arranged, and ICU CT department is and the radiologist immediately informed. As soon as we get a call in casualty, ambulance is sent on a priority basis. Relatives are made in the doctor within the ambulance makes relatives aware of the condition stroke and that there is a need and availability for thrombolysis, and can be done in the first 4.5 hours. Patient is brought in immediately. Emergency ICU and CT scan department is made aware. ABC, the deficit is assessed with the NIH scale, determines the exact time of onset, and the relevant departments are informed, and initial conversation is initiated, and patient is sent to the CT scan, and then fast face, arm, speech, and time. This way the deficit is assessed, and then this NIH scale is a scale which objectively documents a disability by scoring each level of a neurological assessment into 0 to 2 or 0 to 3 points, which includes level of consciousness, orientation, opening eyes to command, gaze, vision, face, motor function of the arms, motor function of the legs, ataxia, sensation, language, speech, and some points called as neglect or extinction. And this is how we grade strokes, either as minor, moderate to severe, or severe based on the NIH scoring, and scoring of 4 and more. But really, even up to 1 to 3 is realized if the deficit is considered clinically significant, such as, for example, aphasia in a school teacher, and there is 3 to 6% of increase in incidence of bleeds based on NIH score. So, immediate CT if patient presents, and what is expected is a normal CT in majority, as Dr. Kulkarni mentioned, and inclusion criteria are applied, which is a focal deficit and no evidence of hemorrhage. And the earlier we thrombolize, the better the outcome. And there are, as I said, some standard exclusion criteria such as prior history of hemorrhage, major surgery, history of bleeding, and then there are relative contraindications in the form of BP and sugar, which I am going to address. And the patient and relatives are counseled, and the dose is 0.9 milligram per kilogram. And then all the departments are trained, NIH scale is recorded, and cost of lysis is discussed, and consent is obtained, and patient is lies, and then continuous monitoring with NIHS is performed, and a CT or MRI is done post-lysis at 24 hours after IV TPA. Certain areas we need to be careful with. Hypoxia should be avoided. It can be because of several reasons, and PO2 and saturation below, say, a certain value mandates intubation. If the GCS is less than 9, and if there is bulbar, that means swallowing dysfunction. And lowering the head increases the blood flow, but if the patient's intracranial pressure is high, we use 15 to 20 degree propped up. Hyperthermia is associated with poor outcome, so that has to be treated. And the blood pressure also has to be managed as that impairs autoregulation, and sugar below 50 and more than 400 carries bad prognosis, should be treated with insulin. And a blood pressure has to be systolic more or less than 180 and diastolic less than 110. Anything below that, do not lower, because it may impair cerebral perfusion, and you can use drugs such as IV labetalol, nicardipine, or clevidipine, but maintain it around 180 and 105 diastolic. So we learned that that up till recently time was brain up to 4.5 hours, but the era has moved from time to mismatch is brain, and I am going to show you how. until recently, guidelines was within 4.5 hours. And as Dr. Kulkarni taught you, CT with perfusion plus core volume or MRI with perfusion and diffusion can show a potentially viable tissue even beyond 4.5 hours. And reperfusion of this mismatch, that is penumbra, that is alive but dysfunctional tissue, can improve functional outcome in patients in strokes beyond 4.5 hours. And here is a trial called a wake-up trial, where MRI-guided thrombolysis for stroke with unknown time of onset was performed. And what they did, Dr. Kulkarni has already mentioned to you, it was a randomized control trial, unknown time of onset in wake-up patients, alteplase versus placebo, that is water. But you had to have visible impact on MRI diffusion, but not on another modality or another sequence of MRI called as flare. And the results were that this is another scale called modified Rankin scale, which objectively gauges the improvement in patients' activities of daily living and ambulation after receiving thrombolysis. And there was a significant improvement in those patients, wake-up patients who received IV thrombolysis with Actylize, wherein the impact was visible on diffusion but not on flare. So here we have a case of a 75-year-old diabetic hypertensive, slept at 11 p.m., woke up at 6:30 p.m. So here, see, the gap has been 7.5 hours, not 4.5 hours. And notice the right weakness, inability to speak fluently. So here, if we see the weakness is in the range of grade 2 to 3. So the NIHS will be at least say 8 to 10, and patients unable to speak. So NIH 8 to 10. Do we thrombolyze? Look, here is a diffusion weighted image where you can see a medium size infarct, but in the flare, in the form of a diffusion restriction, which is seen as a white shadow, but the infarct is not seen on flare image, and already 7.5 hours are passed. It is not within 4.5 hours. And so we have a diffusion flare mismatch. So yes, we will thrombolyze this patient by virtue of this novel trial called as wake-up trial, which has shown is affecting diffusion flare mismatch patients. Another trial, thrombolysis guided by perfusion imaging, the one that Dr. Kulkarni discussed with you. We have this flare, which we learned. Now we have perfusion technique, which and the difference between either core and perfusion or diffusion and perfusion is very important, because that tells us the mismatch, which is the alive and dysfunctional tissue, the penumbra, which can be salvaged by thrombolizing and opening the artery. The name of the trial was EXTEND, which is extending the time for thrombolysis in emergency neurological deficits. The hypothesis was that if we initiate thrombolysis within 4.5 to 9 hours after stroke onset or patient or awakening stroke, that means wake-up stroke, and that it would be beneficial in patients who had a small core volume cerebral infarction disproportionate to a large area of hypoperfusion. The picture that Dr. Kulkarni also showed and I also showed, where the core was small and the perfusion area was large. So CT perfusion versus core or MRI perfusion versus diffusion. And the rapid automated software, the one that Kulkarni mentioned, which we have now at Dinanath, was used to subtract the core from perfusion. We had to have a core volume of less than 70 ml, and the mismatch should have been more than 1.2. So if the perfusion was 120 ml, the core should have been less than or equal to 100 ml. And those were the patients eligible to get into the study. And the same figure that Dr. Kulkarni showed, if the core was, say, for example, here 23 and the perfusion was 28, the mismatch here is 105. This is the 105 ml that we have to bring back to life and make it functional. And there was a favorable outcome with alteplase therapy, and higher percentage of patients came out with minimal deficits, which means the disability score of 0 or 1. And recanalization, reperfusion, early neurological improvement, supported benefit of altiplase. And symptomatic ICH was slightly higher, but very few patients had life-threatening hemorrhage. So the last few messages that I would like to give is in terms of treatment of hyperacute management of acute ischemic stroke, that is cerebral infarctions. Up till 4 or 5 years ago, we were using CT scan, and in selected patients, we were using MRI to make sure that patient has not had a hemorrhagic stroke, and number 2, that the event that the patient has presented with is stroke and not another kind of thing like hyperglycemia or seizure or another cause for deficit, with which we were proving by making use of MRI, and we were lysing patients originally who presented to us with 4.5 hours, and then the concept moved from this time to brain to mismatches brain, and with mismatches brain, we started lysing those wake-up stroke patients who presented with a diffusion flare mismatch. So those patients who had MRI where the infarct was seen on diffusion but was not seen on flare, because it takes around 5 hours for the infarction to be seen on flare, and only within 15 minutes it appears on diffusion weighted imaging. So in those patients, wake-up stroke patients wherein infarcts were seen on diffusion but not on flare, and then we went on to gauge the mismatch by taking help of perfusion weighted imaging either on CT or MRI, and amalgamating these CT or MRI images with rapid software, which through artificial intelligence tells us that there is a significant mismatch with a large area of perfusion deficit compared to the core volume or diffusion deficit. And this is this mismatched area which we can bring back to life, which we can reperfuse, which we can, by opening the artery and give benefit to the patients. So from Chinese brain, we have moved to mismatches brain, and the window for intravenous lysis now with this extended trial has got extended, I must say, from 4.5 to 9 hours. With that, I give you my key messages. Chinese brain within first 4.5 hours, and now mismatches brain up to 9 hours. Thrombolysis is mandatory, guys, and a standard care. Rather, if we don't offer thrombolysis to our patients, if we don't thrombolize our patients, then it could be labeled as medical negligence. Remember that. So make sure the moment you see a patient with stroke, the first thought that should come to your mind, is he a candidate for thrombolysis? At the least IV thrombolysis, and Dr. Beirut is going to tell you which candidates can also go for what we call mechanical thrombectomy. And IV lysis can be performed with CT brain within the first 4.5 hours, and IV lysis can be performed in wake-up stroke patients by documenting, as I said, diffusion flare mismatch. And IV lysis can be performed up to 9 hours using diffusion core volume on CT or diffusion perfusion mismatch on diffusion perfusion mismatch on MRI. So it's not really that bumpy. It's quite straightforward. Thank you very much. I hope I have tried to convey the message and I have got successful in that. Thank you again.
Yes, sir. Thank you. Thank you very much for your excellent lecture, sir, on this topic of IV thrombolysis in stroke management. And you have taken various modalities of thrombolysis at various timing of stroke. So I think it is better for us to know that we can send the patient as early as possible and there should be a facility of CT scan. That has to be there. Thank you very much, sir. I think that there are questions. Dr. Sachin Kumar Khade wants to know role of antiplatelet and dose.
Absolutely. So our goal today on this World Stroke Day is to highlight and enhance the importance of opening acutely, hyperacutely, that is immediately opening the artery for effusing the brain, which is indeed the first step on which all three of us are talking here. But yes, the second step is in the form of antiplatelets, that is aspirin and clopidogrel. And as soon as you make an effort, you made this effort of opening the artery through IV lysis, and if the candidate is eligible through mechanical thrombectomy, and that portion is done, the second step, and obviously you've done the rehabilitation portions, putting the patient in a proper stroke ICU, physiotherapy, airbed, and etc. Then the next step is antiplatelet agents, either in the form of aspirin and clopidogrel. So now here as well, the concept has moved on. Originally, we used to think that aspirin, we used to think the evidence was for aspirin, and then the evidence moved on towards clopidogrel as well with its own advantages. And then both were tried originally as a combined dual antiplatelet therapy. Initial trials showed some increased incidence of hemorrhage, but recently there have been two cardinal trials which have shown benefit of both aspirin and clopidogrel together, and this benefit is much more than aspirin or clopidogrel used single. So now for the first 3 weeks, as far as antiplatelets are concerned, we use a combination of both aspirin and clopidogrel. That is the answer.
Thank you, sir. Thank you. Now I will request our President, Dr. B.L. Deshmukh, to felicitate you.
Sir, this is bouquet for you.
Thank you very much. I hope I was there. Sunil is very close to me, right since our JJ days, but then today I am at Dinana. Sunil, glad.
Thank you.
And this is IMA Upurna for you.
Thank you very much. Thank you.
Thank you, Pujari sir,
Thank you, madam. Thank you.
for being there, and a very excellent talk you have given today. I mean, which could be understood by all of us here in IMA today.
Yeah, thank you, Dr. Pujari. Please stay logged in for a panel discussion at the end. Thank you.
Now I will request our today's webinar coordinator, Dr. Nandakishore Mantri, to introduce Dr. Lomesh Virud.
Thank you, Chirsagare madam. Thanks. Thanks for giving me the opportunity. Friends, recently entered in the galaxy of neurophysician from Pune is none other than Dr. Lomesh Virud. He has done DM Neurology, FSIN, that is a fellowship in stroke and interventional neurology. Dr. Lomesh Virud has done MBBS from Lokmanya Tilak Medical College and Sion Hospital, Mumbai. Then he pursued MD Medicine from Gandhi Medical College, Bhopal. Afterwards, Dr. Virud completed his super specialty in neurology, that is DM Neurology, from Institute of Human Behavior and Allied Sciences, that is IHBS, which is one of the prestigious government institutes of neuropsychiatry of India. He worked at IHBS and then at Zydus Hospital, Anand. Then Dr. Virud pursued fellowship in stroke and interventional neurology, that is FSIN, from Rajagiri Hospital, Kochi, under the guidance of Dr. G.G. Kurutukulam. Then he worked at Kiran Multi Speciality Hospital, Super Specialty Hospital and Research Center at Surat. He is currently working with Ruby Hall Clinic as a full-time dedicated stroke interventional special neurophysician, apart from his routine neurology work. Dr. Lomesh Virud has been trained to do cerebral angiography and mechanical thrombectomy for acute ischemic stroke, aneurysm coiling, carotid angioplasty, stenting, intracranial angioplasty, stenting, and various neurointerventional procedures. So friends, we are really fortunate to have with us an expert in the field of interventional neurology to deliver a talk on the role of mechanical thrombectomy in management of acute ischemic stroke. Over to Dr. Virud, sir. Thank you.
Thank you, sir. Let's go mute from the data. So today I am Dr. Lomesh Virud. I am an intervention neurologist at Ruby Hall Clinic, Pune. And it's pleasure for me to be here in IMA house with all these person here, and thank you very much for inviting me to give a talk on neurointervention in acute ischemic stroke, especially on mechanical thrombectomy. So I have a disclaimer that I have obtained the consents for sharing the videos and photos of my patients. So large vessel occlusion, we discuss about time is brain. So everybody talks about that every minute 1.8 million neurons are going to die. But what really does it matter when we lose 30 minutes? There is 10% reduced chance that you may have good outcome, and that every 30 minutes delay to revascularization causes 7% increase in moderate to severe disability and 11.8% increase in mortality. Looking at the natural history of large vessel occlusion, most of the cases around you will find that 24 to 46% of acute ischemic strokes are large vessel occlusions. When we compare non-large vessel occlusion to large vessel occlusion, the dependency or death at 3 to 6 months is very, very high in patients with large vessel occlusion. The mortality is very much high in large vessel occlusion. The recurrence of stroke is again very high in patients with large vessel occlusion as compared to non-large vessel occlusions. And mind the response to tissue plasminogen activator beyond M3 is very good, but when it comes to ICA, it is only 4 to 8%. When it is M1 is 20 to 30%, M2 is 31 to 44%, and the worst is a basilar artery occlusion, where IV thrombolysis hardly works in 4% of patients. So my simple question: what should I do when I find a patient who is a hemiplegic? I'm just giving an hypothetical example that a 45-year male who presented with acute onset right hemiplegia, aphasia, left gaze preference since last 1 hour in our casualty. In emergency, his vitals were assessed. His CNS wise, he is conscious, poor comprehension, aphasic, left gaze preference, and right hemiplegic. His NIHS score is 20. It indicates that he has a severe stroke, and CT brain is suggestive of left MCA M1 occlusion. As Rahul sir has explained us very well, that this is the MCA dense sign, hyperdense MCA sign, which indicated that the left MCA M1 segment has been occluded, and similarly has been demonstrated on CT angio. So no doubt, since he is in less than 4.5 hours of window, he should receive IV thrombolysis, as explained by Pujari sir very excellently. But apart from that, what should we do? So here there are 10 questions that commonly come in any of our physician. Why it is so important to identify large vessel occlusions? Why I should consider intervention in large vessel occlusions? How I will identify it in my practice? What should be my imaging modality to identify it? I have given IV TPA. Shall I wait to see the response now because the primary treatment has been given? What is the time window for thrombectomy? Which are the vessels shall I target for intervention? What modality of endovascular treatment? How to monitor patients post mechanical thrombectomy, and what are the complications and outcome? Probably when we talk about mechanical thrombectomy, most of the time there are a lot of confusion, or a lot of people will say that it is very costly, your window has been gone, your complications rates are very high, and the outcome is nearly same. So this is not the question. I'll going to demonstrate my all cases of previous institute as well as done at Ruby Hall Clinic, that we have selectively selected the patients, and we have given good outcome in patients with large vessel occlusion. So why it is so important to identify? So the presence of LVO increases 4.5-fold increase of odds of death and 3-fold reduction in good outcome. Basilar is worst, as I told, then ICA, M1, and lastly the M2. When proximal LVO is there, there are more than 7-fold odds of unfavorable outcomes. And mind the recanalization with IV TPA is 6% in ICA and up to 30% in M1 segment. So whether your IV thrombolysis will really benefit, that is a question. And if at all it benefits, it will benefit only in, I'll say 1 in 4 patients when we have considered large vessel occlusion. I'm not talking about the non-large vessel occlusion, I'm talking about only large vessel occlusion. So rates of, when we compare rates and outcome of large vessel occlusion versus non-large vessel occlusion, this was a review article which sees that there is a disproportionate stroke-related dependence as well as death in large vessel occlusion. And when we compare this, large data was studied, they found that there is Among the non-LVO, if you see dependence and death is 24%, whereas among the LVO it is 64%. The p-value was very significant. And when we talk about mortality, the non-LVO is only 1.3%, whereas the LVO is 26%. Means 1 in 4 of LVO is going to die in next 3 to 6 months. So that is probably not acceptable when we have all the infrastructure, all the facilities straight away throughout the corner of the city. So this is also significant. So why I should consider intervention in large vessel occlusion? And the most important factor whenever we talk about medical therapy is number needed to treat. So when we talk about number needed to treat, the best possible number needed to treat is decompression hemicraniectomy for MC occlusions. But that is when the infarct has been occurred. So that number is only 2. Means one among the 2 will survive and probably a bedridden patient. Then immediately perform defibrillation for cardiac arrest. When a patient has been arrested in front of you and you give defibrillation or CPR, that is number needed to 2. But when we talk about thrombectomy, the number needed to treat is only 3. That is the best evolution in last decade has been in medical sciences. When we talk about goal-directed IV antibiotics in acute sepsis, the number needed to treat is 4. As we all know that the thrombolysis has been number needed to treat in first 3 hours is 4 to 5. That is also very good. Even up to 4.5, the number needed is 1 in 9. And when we talk about myocardial infarction, that is very alarming in this number needed to treat. When we consider primary coronary intervention for high-risk ST elevation MI, the number needed to treat is 1 in 12. Still, whenever there is a chest pain, the patient will go to a cardiologist and get his angioplasty or a stenting done, but not in LVO. When patient is in need, should be undergo mechanical thrombectomy. So when all the trials of mechanical thrombectomy was studied and will evaluate, the number needed to treat is less than 3. So out of 3, the one patient will live his life as that of previous. So that effective this treatment modality is. So now there is no question, and this trial has been published in this year only, that number needed to treat in large vessel occlusion is only 3. So this is a huge number, I'll say. So what it impacts on recanalization? So we are talking about why it is so important to achieve recanalization. Everybody was talking with whether it will be IV thrombolytic agent or whether it will be mechanical thrombectomy. This was a pooled study of all more than 2,000 patients. There may be a spontaneous recanalization which occurs in only 24%, but when you give IV TPA, the chances will be 46%. And when we consider mechanical thrombectomy, you can increase the chances up to 83%. So when you talk about good outcome at 3 months, look at the odds ratio. Do you have a very good odds ratio when you non-recanalize the patient versus recanalize the patient? And look at the fatal outcomes in patients who has been received mechanical thrombectomy within 6 hours. The odds ratio is very good. If you don't recanalize, your 41% patient will have been suffering, and if you recanalize, only 12 to 14% patients. And whenever we talk about the hemorrhagic transformation, in both the arms, the hemorrhagic transformation is same. So there is no difference. So that is very important. But how I will identify it in my practice? That is the main question. We saw in and out all the hemiparetic patients, but how should I know that clinically that this patient maybe have a large vessel occlusion? So there is a simple stroke scale to identify large vessel occlusion. When we talk about FAST or B-FAST, when we have to identify only stroke, so it is very easy to say that acute onset balance problem or vision problem or a facial deviation, arm problem, speech problem, and then you notice the T. So B-FAST is a worldwide very, I'll say, emphasized on diagnosing acute stroke clinically. So when we talk about large vessel occlusion, what is the scale? So the scale is simple, VAN, V-A-N. There is S or no. The question answer is S or no. VAN. V is visual disturbances, whether the patient has a gaze preference or homonymous hemianopia. A is aphasia or arm weakness, and N is a neglect. So neglect demonstrate that right hemisphere, your aphasia demonstrate left hemisphere, vision disturbances or gaze preference will demonstrate your either of the frontal lobe involvement, and arm, definitely arm is very important when it is a dominant limb or a non-dominant limb. We need to work with the arm. So VAN, whether VAN plus or no, either of one is present, the sensitivity is 100%. Mind you are clinically are very sure that this is going to be a large vessel. Your chances of getting CT angio showing large vessel occlusion is 100% and specificity is 90%. What else? If you don't get it, that is also okay. But you have an attempt that clinically you are able to identify that the patient was suffering from a large vessel occlusion. So the stroke scale for large vessel occlusion is very simple. So when we talk about fast and talk about NIHSS, the one more word we have to add in our stroke severity is VAN. So this patient has came with the fast positive. So he's in window period. His NIHSS was 10 and Dr. Van is positive. So he is definitely have a gaze preference and a neglect or aphasia. Van is positive. So the opposite person to whom you are taking a call, understand that this patient had a large vessel occlusion clinically. So what guidelines is, what is the imaging modality for once you identified that clinically that this patient has a large vessel occlusion, so in your time window is less than 6 hours, what the guidelines say, you have to obtain a non-invasive vessel imaging for intracranial arteries, and the current level of evidence is 1A. So if your patient is less than 6 hours and your NIHSS is 8 or more than 6, I'll say, you have to have non-invasive vessel imaging at the same point. So whenever you are shifting a patient for a CT, ask the patient will require a CT angiogram as well. So we'll able to know that this patient had a vessel occlusion and the level of evidence is 1A. And there is no requirement of checking the creatinine, especially when you are considering the contrast angiography in CT. There is always a priority of neurons over nephrons. You can dialyze once you have a kidney failure, but you can't replace the neurons. So, and that even the nephrotoxicity will be transient, patient will come out. So there is no requirement of creatinine for a CT angiogram. You don't have to wait for creatinine because every minute you are losing millions of neurons. So when your time window is 6 to 24 hours for large vessel occlusion, what they say, you either obtain a CT perfusion study or obtain a diffusion weighted MRI with or without MR perfusion that aids into selection for mechanical thrombectomy. And the level of evidence is again 1A. So first 24 hours you have identified the patient had a large vessel occlusion, you should do a angiogram with or without a perfusion study. So why it is so important now, I'll explain that the patient has been received alteplase or tenecteplase in emergency room. Now I'll wait whether I see the patient will getting response or not. Whether shall I wait or not, that is a question. But on the point of time when we identified there is a large vessel occlusion, there is no way that we have to wait to see the response. If you lose by 1 hour also, if you see that the treating odds ratio at our 3, 6 and 8, you are getting the benefit is going to be very less, 39%, 30%, 15.7%. So every minute is going to count for you. So what guidelines say? Guidelines says that in patient who has been a candidate for thrombectomy, observation with IV alteplase to assess clinical response should not be performed. The level of evidence is harm. It is causing harm. So when we talk about medical legal consequences, this is the latest guideline which says that you don't have to wait when you have given IV TPA and the patient was suffering from large vessel occlusion. That is not an indication. So you have to shift this patient to center where the thrombectomy is available. So when we know that this is a patient who had been a candidate for thrombectomy, then what is my time window to perform thrombectomy? So if your patient has been time window less than 6 hours, The causative occlusion is ICA, MCA, M1, age is more than 18, NIHS is more than 6, CT aspect is more than 6, groin puncture you can initiate within 6 hours, and the pre-stroke MRS. We are not going to offer this patient thrombectomy to the patient who has been bedridden, advanced Parkinson disease, advanced Alzheimer's disease. So your pre-stroke MRS score should be 0 to 1. 0 to 1 means 0 is absolutely normal. 1 is slight disability, but he is able to do his all activities of daily living. So that is should be our inclusion criteria when we consider for thrombectomy. So the level of evidence is again 1A. So in court of law, when you are not offering a thrombectomy, you may be liable for the medical negligence nowadays. So when we talk about time window of 6 to 16 hours, and you demonstrate there is a core and penumbra, if your penumbra is more than 1.8 times of your core, and there is occlusion of proximal MCA or ICA, the diffuse 3 trials has demonstrated there is a very good benefit, and the level of evidence is again 1A. So your level of evidence 1A has been moved up to 16 hours when we talk about large vessel occlusion. Only the thing is that we have to demonstrate that the patient has a salvageable brain tissue by doing CT perfusion study or by doing diffusion weighted imaging and just check with the clinical correlations. What about time window between 6 to 24 hours? The Dawn criteria, which has been demonstrated that the proximal MCA ICA occlusion, and you have a mismatch criteria defined according to age less than 80 or more than 80. When there is a salvageable tissue or penumbra, we have to proceed for thrombectomy. The level of evidence is 2A. So that is also good evidence. I'll say that the benefit is much more than the risk. So to conclude this diffusion mismatch and everything story, so just see there is a clinical core mismatch, means a combination of high NIHSS and the imaging either on CT perfusion or a diffusion, which is very less, means your perfusion is very high and the core is very small, and you have a large vessel occlusion, for example ICA occlusion or MCA M1 occlusion. Then mechanical thrombectomy in patients with 6 to 24 hours of last well known is useful. So when we talk about thrombectomy, doctor, what are the vessels we should target for intervention? So ICA, MCA, M1, there is no doubt the level of evidence is now 1A. So every ICA occlusion or MCA M1 occlusion who are in window period or who are between 6 to 24 hours with demonstrable salvageable penumbra, we have to go ahead for thrombectomy. For MCA M2, M3, the level of evidence is 2B. Still benefit. For bacillar, the trials has been not yet demonstrated, but we know that the bacillar has the worst outcome in all strokes, so they should be offered mechanical thrombectomy. So our ACA, PCA, the current level of evidence is only on the expert opinion. So we definitely understood now by this that the vessels which we are going to target is ICA, MCA, M1, M2 and bacillar. So what modality of treatment and endovascular goal of our endovascular treatment? When we talk about what modality, doctor, you have used for achieving the recanalization or thrombectomy, or what is your goal of endovascular treatment? So modality, stent retriever thrombectomy or aspiration. I'll show you the cases so that we'll better understand what is this. And my goal is to achieve MTK2B3. Like TIMI score in acute MI, we have a TIKI score in acute ischemic strokes, and our aim, our goal to achieve by 2B3 mechanical thrombectomy, and the level of evidence is 1A. So I'll just brief you what is ADAPT or aspiration, direct aspiration. We have a large bore catheter up here. We approximate this large bore catheter till the clot segment, and with the negative pressure suction we aspirate this clot. So this is aspiration. We are going to produce a negative suction pressure at the base of this clot and we just aspirate it. And second is a stent retriever thrombectomy, where across this clot we put a stent retriever and we pull out this clot with the help of either balloon guide or non-balloon guide. It doesn't make any significance because the level of evidence is still 2A. And last is a Solumbra, where we use the combination. When there is a hard clot, we have to pass a stent retriever across the clot. We have to apply a negative suction pressure at the tip of the clot, and with combination of this, we take out this. This is called Solumbra. So these are the three basic modalities of endovascular treatment we are doing routinely. So I'm going to talk about with the cases how we have done. So this is, I'll go by examples, and from this onwards there will be all cases and discussion on the cases as well. The few cases are of my previous center where the Gujarati was the predominant language. So I'll be speaking little Gujarati to my patients.
क्या नाम है? नाम दिखा, जीभ दिखाओ.
So this patient had a good comprehension.
बीचा पग उठाओ.
He had a right gaze preference.
ये वाला पैर उठाओ. बहुत अच्छे उठाओ. बहुत अच्छे उठाओ. कोशिश करो.
Left lower limb was weak. Bija means other.
ये हाथ उठाओ. ये वाला हाथ उठाओ.
So left upper limb was pelagic. When we are talking about arm weakness, see this, the pelagic. He had a gaze preference to right side.
नाम बताइए. ठीक. कहाँ रहते हैं? ठीक है. जीभ बताओ.
So his comprehension was intact. He is a 60-year male, 2 hours of onset, left hemiparesis, gaze preference to right. NIHS was 14. MRI, MR angio was showing right MC M1 occlusion, and he received IVT in emergency. From emergency onwards, he was immediately shifted to cath lab, where we have done a diagnostic cerebral angiography, and which is showing a distal M1 cutoff, and this area was hypoperfused here. So we immediately take our stent retriever up. We have taken microwire microcatheter up into the distal vessel. We demonstrated that that we are in a proper vessel, and after that we deployed the stent retriever. These are the markers of stent retriever. We can see with zoom. These are the stent retriever markers. This is completely opened up stent. This is the distal marker of the stent retriever. This is the distal, and after that the complete recanalization was achieved. So this is immediately after 6 hours of the procedure.
कहाँ रहते हैं? जीभ दिखाओ.
So gaze preference was improved.
बाजू देखो. इस बाजू देखो. ये हाथ उठाओ. बहुत अच्छे. बीजा हाथ उठाओ.
Bija means other.
रखो.
Has been improved with the pelagic limb.
ये पग उठाओ. उठा के रखाओ पग. ठीक है. ये वाला पग उठाओ. ठीक है. नीचे रख देंगे. इस तरह दांत दिखा. नाम बोलिए फिर से.
So this was a stent retriever, and this was the clot which has been pulled out into the stent retriever. So we'll move to the other case. This was a 48-year male, 1 hour of onset of left hemiparesis, gaze preference to right. NIHS was 14, again indicate that he had a severe stroke, and the MR angio was showing right ICA occlusion. Since the patient is within window period, we have to give thrombolytic agent. There is no excuse in deferring the thrombolytic agent until and unless there is a contraindication. So we should find the reason to treat rather than doing excuse for any treatment. So this patient again completely looking on the right side,
जीभ दिखाओ.
able to understand.
हाथ उठाओ. ये हाथ उठाओ. दाबो हाथ उठाओ.
Dabo is left.
जमनो हाथ उठाओ.
So we took immediately to cath lab table. This patient is on cath lab table.
दाबो पग उठाओ. दाबो. दाबो पग उठाओ.
Dabo is less. He had been a left hemiparetic.
ये करो. ये करो. ये करो. दांत दिखाओ. दांत दिखाओ.
So after that we took our initial run diagnostic cerebral angiography. This was the ICA vessel which at the end ends up abruptly. So it was indicate that this patient had a distal ICA occlusion. This was our aspiration catheter. We have applied the negative aspiration at this catheter, and after that we achieved recanalization. So patient has achieved recanalization within 3 hours, and you can see the patient.
आ रहे थे चल के दिखाएंगे और जैसो
फरीजा से घूम जाइए, टर्न अराउंड.
चलो और जैसो जाओ ये कीजिए
Happy to receive the treatment in time. So this was another, nowadays the young stroke has been increasing. This is another case. We had a 28-year male, 1 hour onset, right hemiparesis, gaze preference to left, and aphasic with impaired comprehension. NIHS was 18. Again indicates that this patient had a large vessel occlusion. MR angio suggestive of left M1 occlusion, and again received IVT. So my first 5 cases will be that within the window period, and more than next 5 cases will be apart from the window period. So this patient, again a young male, impaired consciousness
आगे खोलो
with deep painful stimuli, also he is not waking up. So again on cath lab table, patient is in cath lab table after IVT. So immediately we took a DSA run. The DSA was suggestive of left M1 occlusion. We are talking about the collaterals. This patient had a very good collateral. So definitely, anyway, this patient was in window period. He is going to benefit with thrombectomy. But to demonstrate that this patient had a good collaterals, so we immediately took for aspiration catheter up and aspirated the clot, and we are able to achieve successful recanalization within time. So when patient came to the OPD, slight anomia, but patient has resumed his activities of daily living. That is the best thing of this treatment. So this is an interesting case. He was a 35-year male, known case of post-aortic wall replacement on warfarin, 2 hours of onset. He presented only with aphasia. So aphasia by calculating NIHSS will be very less. But just imagine that the patient will not able to talk for his rest of life. That will cause a major disability. So considering the major disability of that aphasia, we have to have intervene, but unfortunately his INR was 2.3, so we are not able to offer him IV thrombolytic agent. So INR more than 1.7 is a contraindication for IV thrombolytic agent, and his INR was 2.3 since he was on warfarin. So MR angio was suggestive of left M2 occlusion, and there is a contraindication for IVT. So let's see what we have offered him. This is an emergency room. Patient is able to understand, but he is not able to speak. So he had a predominantly motor aphasia, Broca's aphasia, subtle weakness in right upper limb, slight impaired comprehension, and a right UMN facial paresis. So we took him immediately for cath lab, and we demonstrated there is a M2 occlusion. We immediately passed our aspiration catheter up to suck out the clot, and after the aspiration thrombectomy, we are able to achieve the recanalization. And immediately after 1 hour, बर्तन का दुकान है, सो बोलना तो बहुत पड़ेगा इसको. So when So when this patient achieved his speech back, then he told that he has a medical policy. So just see that the patient was not able to talk. Even he had a medical policy, he might not have received his best treatment. Once he achieved the speech, he was telling that he has a medical policy. So the among the window period, the last case, 65-year male, 2 hours of onset, left hemiparesis, dysarthria, facial deviation, and gaze preference. NHS was 8. MRI suggestive of M1 occlusion, and received IVT as our protocol. So there is a evolving infarct in the MCA M1 territory. There is a diffusion restriction and low values on ADC. MR angio was showing M1 occlusion. Patient again was taken up for immediately for cath lab, which is demonstrated that the M1 was cut off. We are talking about the collaterals. When there is good collaterals, there is definitely patient will get benefit of this. On lateral projection, we are able to demonstrate there is a visible clot in the vessel. So there is a visible clot in the vessel. So again, we took up our microcatheter microwire up into the distal vessel. So we take a shoot, we deployed the stent retriever. This is the stent retriever markers, and we achieved full recanalization of MCA M1 territory. So this was a stent retriever technique.
Yeah. काय नाव आहे तुमचं? पूर्ण नाव सांगा. पूर्ण नाव सांगा. ई करा दाखवा. दोघं हात वर करा. कसे आहात आता?
The patient is fine after receiving thrombectomy. So when we talk about first 6 hours, there is no doubt we should offer mechanical thrombectomy. When we talk about beyond 6 hours, we have some dilemma when offer or not to offer. So we are talking about clinical core mismatch. This is the case 6, is at around 10 p.m. in night, 68-year male who had a 10 hours of onset, right hemiplegia, global aphasia, facial deviation. NHS was 14, MRI was a left MCA developing infarct and a left ICA occlusion. So there was a MCA developing infarct. So when we compare that, NHS was severe and still the patient had a very minimal infarct in the diffusion. So there is definitely clinical core mismatch, and MR angio, there is no visualization of ICA, no visualization of MCA. So such patient we immediately take for cath lab just to see how's the vessel there. So this was the pre-mechanical thrombectomy video for this patient. He is in the cath lab table. Patient has global aphasia. Comprehension is very poor. Right upper limb, lower limb was plegic. Patient has poor comprehension, aphasic, right hemiplegic, and this was his angio. In DSA, there was a dominant left MCA M2 occlusion, and since there was a salvageable brain tissue in diffusion scan, we went ahead with the thrombectomy, and we have achieved successful recanalization of TK2B3. This was the clot which was captured into the M1 stent retriever. This was the clot. On closer look, we can see this clot which has been causing left M2 occlusion. So in follow, the patient has come to us. He still has some aphasia component, but he has able to achieve his mobility. Patient is slightly dentulous. Dattatare Pravar, he is telling slight Paddachir, he is fine. So another lady, that slight facial deviation. The left upper limb was paretic. Just see she is not able to hold his arm.
डावा पाय वर कर.
So looking at her NIHS is very less, considering only NIHS is 4, left hemiparesis, facial deviation, 8 hours of onset. The right MCA, there was a developing infarct, and right M2 occlusion we were able to demonstrate. So we know that this M2 may cause major deficit for her in coming hours. We immediately took her for a DSA, which is demonstrated that this patient had a M2 occlusion. With obtaining consent beyond 6 hours and M2 occlusion, we advance our aspiration catheter up, and we just pulled out the clot, and she achieved MTK 2B3 recanalization. And post-op day 1, the paretic limb has been completely normalized. It's just a young female. So this was a M2 occlusion for her, and we have achieved complete recanalization. It was beyond 6 hours, and we are able to demonstrate there is a clot around 4 mm. So another case who is again beyond 6 hours, 8 hours of onset, 63 male, came at emergency 11:30 p.m. Left hemiplegia, right gaze preference, impaired consciousness, and facial deviation. By and large, looks like a major stroke. NIH is 14. MR angio was showing right ICA developing infarct and right distal ICA occlusion. So this was the patient in emergency room. His comprehension is very poor. Gaze preference to right. Eyes are towards right. Patient is irritable. Not able to move left upper limb on deep painful stimuli as well. So limb was completely plegic. So beyond a window for IV thrombolysis and a major vessel occlusion, and there is a developing infarct. So we took immediately to the cath lab. The ICA shoot was showing that distal ICA was occluded. This was ophthalmic artery. This is posterior communicating artery. The distal ICA is occluded. We took our aspiration catheter directly till this clot segment, and we open up the ICA vessel. This was the clot which has been aspirated from the vessel, which is around 18 mm in length. So this was immediately day 2 of the procedure. Patient has able to achieve his mobility.
दोनों हाथ ऊपर करो. दोनों हाथ ऊपर करो. क्या नाम है आपका?
Ranjit Singh Kakda.
इधर रुको, देखो. कैसे हैं आप? ठीक करो. दांत दिखाओ. दांत दिखाओ. ठीक है.
So patient improved very well following thrombectomy. On day 2 only he has achieved his mobility. So this was our cath lab team. My brother both brothers, Mehnaz and Adarsh, and our cardiac anesthetist, Dr. Kaustub. This is me. This is ground staff, and Joel was a cath lab technician. We are opening this vessel in middle of night. This is another case beyond window again, beyond this, and this was a wake-up stroke. When we talk about wake-up stroke, whether to give them IV thrombolysis or not, depending on our MRI studies and MR perfusion studies, some candidates are eligible for IV thrombolysis, but some may not. So this was in morning for 5 a.m., 60-year male, wake-up stroke, left hemiplegia, right gaze preference, facial deviation. Patient was brought immediately to emergency. NIHS was 14, again showing right MCA developing infarct and MCA M1 occlusion. He is able to understand. The gaze is on the right, is not able to look on the left. The left upper limb was plegic.
डावा पाय उचला.
Lower limb was plegic.
डावा पाय उचला. उजवा पाय उचला. उजवा हात उचला. ठीक करा. ठीक करा. दांत दाखवा.
Facial deviation and right gaze preference. So we again took him immediately to the cath lab. The right ICA was critically stenosed. There is a stenotic segment as well as there is a small clot in this stenotic segment. The right MCA M1 was occluded. So sometimes we call this there's a tandem occlusion. There is an occlusion in the proximal segment as well as in the distal segment. These are called tandem occlusions. So we took him, we need to take for thrombectomy, but that occlusion will cause our materials to track upside. This patient, once we are sure that the microwire microcatheter will track, we advance our microwire and microcatheter. We again confirm the position of our microcatheter. Then we deployed a stent retriever. These are the markers of stent retriever. You can see there are 3 markers across the stent retriever. And following stent retriever thrombectomy, we are able to achieve MTK3 recanalization. And this was the clot which has been taken out from the MCA M1 segment. And this was the patient in follow-up. So later on, we offered him carotid stenting. So patient received stage carotid stenting in this case. So my last case, again wake-up stroke. At 6 a.m. on the day of Diwali last year, a 56-year female wake-up stroke, left upper limb monoplegia, facial deviation, NIHSS 6, MR angio and MR suggestive of right MCA developing infarct and right ICA occlusion. So since the wake-up stroke, there is a developing infarct in the MCA territory, and there is no visualization of ICA as well as MCA. So invariably this patient will develop a major stroke if we don't treat in time. So this was in the cath lab table. We took the patient. Patient is able to speak. Subtle facial deviation on the left side. Right upper limb is fine. Left upper limb is completely plegic. She is not able to lift left upper limb. So again, we have to take this patient for immediately carotid angioplasty as the ICA was very bad, which is a stenotic here. So we did a angioplasty with 615 mm balloon. After once we are sure that our microwire microcatheter will track, we went ahead and taken out this clot with a stent retriever thrombectomy. This was the clot which has been taken out from the thrombectomy. And immediately in the cath lab only on table, patient improved. This is the cath lab panel behind. होता है वर पूर्ण. So patient was on cath lab table. Since that right carotid was very diseased, and we have done angioplasty to that vessel, invariably these vessels are over time get again closed. So we have decided to do an emergency carotid stenting for this patient. So we advanced the carotid stents up, deployed the stent, and there is well opened stent. But once we deployed the stent, we have to wait for at least 30 minutes to 1 hour to just see to there is no in-stent thrombosis. So unfortunately this patient, there was a good flow, and patient developed in-stent thrombosis. So we again have to give intra-arterial tyrofibin injection, and after 1 hour the stent thrombus was resolved. So we have done at least 2 hours check shoots, and patient was stable and discharged home. So patient received emergency carotid stenting and mechanical thrombectomy in that Diwali, and that was the best gift for her on Diwali to achieve her mobility back. So how to monitor patients with mechanical thrombectomy post? Our aim is to keep the blood pressure less than 180 or 105. We prefer to be 160/90 in our setup. but guidelines says 185, 105 is sufficient. Apart from airway breathing circulation, GCS pupils, and periodic assessment of NIHSS, which tells us the patient has been deteriorated or not. And the most important, whenever we are going to puncture the right femoral or left femoral artery, we have to see the access site. So whenever we patient do very well procedure intracranially, but we lose the patient because of the access site problems. So everything comes with some cost. So there is not always there is 100% foolproof any treatment modality. So mechanical thrombectomy it itself has some procedure related complications. So there may be embolization to another territory. We may cause arterial perforation, we may cause arterial dissection, we may have access site hematomas, and sometimes because of general anesthesia also patient will have aspiration issues, or after they take time to come out of general anesthesia as well. So everything has a cost. You do very good successful recanalization in patients with M1 occlusion. You have achieved very good recanalization. Unfortunately, patient may develop reperfusion injury. So there may be gyral enhancement which increases, and patient will develop mass effect and midline shift. So again, this is complication due to reperfusion. Whenever there is a vessel is closed, the brain parenchyma is going to tolerate that ischemia, and once you open it, the blood-brain barrier has been already disrupted. So patient may develop reperfusion injury. So again, access site evaluation, patient may develop groin hematoma. There may be a pseudoaneurysm formation. There may be, if you have a high puncture, the patient may get retroperitoneal hemorrhage. Patient may have contrast allergy once we are pushing contrast, or a contrast nephropathy as well. So one of my patient has developed right femoral pseudoaneurysm. So once the puncture was exactly on the femoral head and we are able to see the neck of pseudoaneurysm, we have given 30 minutes compression over that neck, and the pseudoaneurysm was disappeared, or else we have to do manage endovascularly sometimes. So everything has a cost. So there are a lot of factors affecting the outcome of stroke, endovascular stroke therapy. Patient-related factor like age, NIHSS at onset of symptoms and comorbidities. Radiological like admission, neuroimaging, or posterior. How's the arterial access? You have a femoral issues, arch problem, extracranial, intracranial vessels problem. Or system factor. Sometimes there may be the hospital is very far from their place, access to neuroangiography suite, many times you don't get cath lab, day versus night. In fact, I'll say that most of the stroke thrombectomies are in our country are done at night. Daytime, mostly the cardiologist occupied their all the cath labs. Weekdays or weekends, patient are get attended on weekdays. Weekend, the patient are not attended. And experience of the team. So all these factors affect the endovascular stroke treatment. And there are a lot of poor outcome factors as well in stroke therapy when we are counseling the patient or patient relatives that whether this procedure will get successful, not successful, or there may be procedure failure also. So if you are not able to access till the clot, that may be access failure. You are not able to recanalize, which will be tricky to 0-2A, which can occur in 5 to 10% of patients. Embolism to new territory, which can occur at 3 to 4% of patients. And intra-procedure, when you are doing the procedure, there is a decay in the aspect, means your collaterals are failing and your salvageable brain tissue gets reduced. So that also counts in the procedural failure. Post-procedure failure, we call when there development of symptomatic ICH, parenchymal hemorrhage type 2, patient requirement of decompressive surgery, or patient having MRS of more than 3 at 3 months. So this also counts for this poor outcome in endovascular stroke therapy. So coming back to my main question to all of us, that this was a 45-year male who presented with right onset hemiplegia, and the NIHS was 20, and you know that the CT angio is showing left M1 occlusion. So what shall I do? What shall I do? I have to assess signs of large vessel occlusion. I will evaluate this patient for IV thrombolysis. If it is less than 4.5 hours, there is no doubt until unless it is very much contraindication, you have to defer thrombolysis. You have to inform immediately a neurologist or an intervention neurologist or an intervention radiologist or a neuroradiologist. Consider for early intervention to save neurons, because if you save penumbra, then only your patient is going to benefit. The core tissue is already damaged. There is no point in targeting core. Our whole aim of doing all this exercise of IV thrombolysis or mechanical thrombectomy is to save the penumbra. So when we save the penumbra, the patient will get benefit. We have to immediately inform to cath lab team for mechanical thrombectomy. Now we have understood that the number needed to treat is less than 3, and mechanical thrombectomy is much should be prioritized than acute myocardial infarction. And we have to evaluate for risk factors and its management, and again the prevention and rehabilitation. So that is our main goal of targeting these patients. So just to highlight, in emergency room, what should be our protocol when patient has come to acute focal neurological deficit, for example, just hemiparesis or just aphasia or just vision loss, whichever acutely occurring neurological deficit has to be a vascular cause. So we have to assess GCS, airway breathing circulation. Time of onset is very important. Immediately check blood pressure, random blood sugar and EKG. Time of onset is less than 6 hours or more than 6 hours. Immediately shift the patient to CT or MR with angio. Assess the patient for eligibility for thrombolysis. Assess the patient for eligibility for mechanical thrombectomy. Assess the patient's NIHSS. If it is less than 4 and improving deficit, we have to consider thrombolysis with consultation, not directly. If it is 4 to 6 or more than 6, thrombolysis immediately. If it is a large vessel occlusion, shift the patient immediately to the angio suite for angiography, and depending on whether the patient has recanalized with IV TPA, he might not require mechanical thrombectomy or else need a thrombectomy. If it is a hemorrhagic stroke, for example, hypertensive bleed or subarachnoid hemorrhage, vascular malformation, still you have to consider for DSA, or lastly may have cerebral venous sinus thrombosis. So with this talk, I think I have covered all the important aspects of acute focal neurological deficit in this slide. And I hope that all of us has now understood that the large vessel occlusion has been the tremendous burden on our population as well as the caregivers, and we must act very fast to get the recanalization as early as possible. With that, thank you very much, and thank you for the organizing committee to giving me such a good opportunity to talk on this upcoming intervention.
Hello. Yes, one question was that is the recovery complete? That is all. Is it 100% or is it say 90%, 80%, and then it goes on to recover to 100% later on with physiotherapy? So how do you assess the complete recovery of the patients of this paraplegia or hemiplegia?
So our primary goal for this treatment is to achieve recanalization. Once you achieve the recanalization, over a time, these patients do get benefit. The immediate benefit is because of revascularization. The later benefit is because of our secondary prevention, as well as physiotherapy, as well as development of collaterals if there is a persistent occlusion in some form. So this patient definitely get benefit with secondary prevention and physiotherapy as well. The maximum recovery can occur up to 3 months, and at the end of 3 months, we generally say that this can be a maximum.
So why the thrombolysis results for basilar circulation are much worse compared to ICA or HCA? Why? Because Dr. Pujari also mentioned the same thing.
Very good question. So whenever there is a vessel which is end vessel, for example, basilar we do call it as an end vessel, 2 vertebral arteries joins and forms a basilar. Fortunately, there can be a peak of circulation
but that can occur in only 30 to 40% of patients or general population. So there are very less collaterals in patients with posterior circulation. Secondly, the posterior circulation, it has its own drawbacks because the brain vital organs are there in the brainstem. It's not like you just have sensory deficit or aphasia. You will definitely have some cardiorespiratory problem or impaired consciousness or level of I'll say mobility, because the pons is very important structures, thalamus is very important structures, your medulla is very important structures, and if your large cerebellar involvement is there, that will cause mass effect of brainstem. So that's why the basilar artery occlusions are the worst in acute ischemic strokes.
So thank you, Dr. Birut sir. Excellent presentation. And you have enlightened us on a various aspect of modalities of endovascular procedures as far as this acute ischemic stroke is concerned. Thank you very much. And all the speakers, Dr. Rahul Kulkarni, Dr. Shripat Pujari, and Dr. Birut. It was really academic feast for all of us on occasion of World Stroke Day. Thank you very much. Sir, there are a few questions. Dr. Naurangesar has already asked one. His one more question is now to Naurangesar. In case of TIA, should we subject patient for a CT angio?
So, as Rahul sir as well as Shripat sir both told, the stroke is a disease of vessel. It's not a brain parenchymal disease. It's a disease of vessels which supply the cerebral hemispheres. So in the TIA, we have to do a angiography, either a CT angiography or MR angiography. So we have to evaluate the vessels. That's the answer. And apart from that vessels, we have to evaluate for a cardiac, because if you see cardioembolic stroke may present like TIA. So these two things has to be done in TIA patients.
Okay, thank you, sir. So one more question again from Dr. Naurangesar. You have mentioned MC of occlusion, but what is the M1, M2?
Okay, MCA, I have not explained little bit anatomy. So I'll just go back to my slide. So this vessel,
Screen sharing the right.
In this vessel, you are able to see this MCA M1, which is cut off here on the left side. When it divides into two, it is called M2 segment. Okay. When it further divides, it's called M3. And till cortex, it is called M5, M6. Okay. So depending on the division, the vessel number is given. So only one is M1, when two, M2, when 3 or 4, M3, M4, and lastly, when till reach cortex, it is M5, M6.
Thank you, sir. Thank you, sir. So you have mentioned about VAN. So I think V for stands for vessel, A for aphasia and arm, and you say you mentioned neglect. So what is neglect here?
Okay, V is for basically vision.
Vision.
I'll say vision rather than you have to have either gaze preference, homonymous hemianopia, or vision loss. So gaze preference indicates there is an involvement of cerebral cortex. Homonymous hemianopia indicates that there is an involvement of posterior cerebral artery. And lastly, vision loss, that indicates that maybe patient acute vision loss. In patients who had acute carotid occlusion, they will have vision loss. They may not complain it, but they will have the vision loss. Sometimes the patient will come only with vision loss because that carotid stenosis, the small plaques ruptures, small clots goes into the ophthalmic artery only. So this patient had acute vision loss. So that V stands for vision, either homonymous hemianopia, gaze preference, or vision loss. A is a arm weakness. You may have a upper limb weakness, that is plegic. Or second A is aphasia. That indicates left hemisphere. Most of the time the left hemisphere is dominant. In left-handed person, there may be a right hemisphere dominant. So AF is for aphasia and N is a neglect. If you see that when your patient of right ICA occlusion or MCA occlusion, they were just neglecting on the left side of body. So they are not aware that they have a plagia. That is neglect. They are not able to assess that they have a weakness in upper limb and lower limb on the left side. So neglect indicates non-dominant hemisphere involvement.
Okay, thank you, sir. Sir, in a management of this acute ischemic stroke, can intravenous thrombolysis and endovascular mechanical thrombectomy can be done simultaneously?
We have to do it simultaneously. Once in emergency room that you know that the patient has a large vessel occlusion or non-large vessel occlusion. For example, if your patient is a candidate for IV thrombolysis, you have to thrombolyze. There is no question in that. If it is a large vessel occlusion, you just thrombolyze and shift the patient to cath lab. Do a angiography, BSA, and demonstrate that there is vessel occlusion or not a vessel occlusion. Many times, you thrombolyze patient in the emergency room. By that time, 10 or 15 minutes, when patient is in cath lab, patient has been improved with deficit. You took the angio shoot, the clot has been disappeared. That is the beauty of IV thrombolysis. And that can occur in 10 to 20% of patients who has a recanalization with IV TPA. So IV TPA has to be given and immediately you have to shift the patient to cath lab.
Okay, thank you, sir. Sir, what is the period, duration, earliest period or उशिरा दुसरा आपण केव्हा करू शकतो?
Thrombectomy, thrombolysis.
Both.
For thrombolysis, the guideline says up to 4.5 hours you have to thrombolyze non-LVO, LVO, any kind of patients until and unless there is a major contraindication. So when we talk about major contraindication like bleeding diathesis, INR is more than 1.7, patient had a sustained major injury, head injury or a GI injury, or recent blood loss, I'll say GI blood loss. So these are the major contraindications for IV thrombolysis. Less than 4.5 hours, no contraindication, just give thrombolytic agent. And for thrombectomy, the window has been shifted till 24 hours, depending on the patient had a salvageable brain tissue. So when we talk about time is brain, now the people are moving that tissue is a brain. When you have a viable tissue, you have to intervene. If you don't have viable tissue, don't intervene. And for viability, we do check clinical core mismatch by diffusion weighted MRI or CT perfusion study or MR perfusion study. So if you demonstrate this, go ahead and do a thrombectomy.
Thank you, sir. Sir, now last question, which is very near and dear to us, dear to our heart. What is the cost of the mechanical therapy?
This is a very common question that what is the cost of therapy? But for me, when we talk about cost, we must understand what is the patient's ability to do after this. If you don't do this thrombectomy, which may cost about 4 to 5 lakhs, or in some cases up to 3 lakhs also, and if you do not, you just wanted to save this 3 lakhs or 5 lakhs, this patient is going to be bedridden for lifelong. He is not earning. One of the family member has to be taken care of the patient. So that's why I think the cost should not be a matter of concern when we offer a thrombectomy or any endovascular treatment.
Thank you very much.
Can I just say,
request,
can I just say one thing? As Dr. Birud rightly has mentioned, there have been studies, reports of patient cohorts where those patients who are not thrombolyzed, and like Dr. Birud was saying, the cumulative costs of managing these patients, as he rightly said, staggered on for years more than what the cost of thrombectomy was. So actually, appears to us as a one-time expenditure of 5 lakhs, but if we don't do, then the cumulative cost of the care of a bedridden or disabled stroke patient is much higher than these 5 lakhs. And if the expenditures were actually calculated more in dollars there in US. Even there, the expenditure of care was more. This is the only thing I wanted to say.
Yeah, right, sir. You are right. So thank you, sir. Now I request Dr. Birut, sir, to conduct panel discussion for few. Thank you, sir.
Any questions which can come to the mind of a family physician, if you can just point out, sir, because I have got one question from the patient's point of view. Yes, this question can be directed to Dr. Viru, Dr. Pujari, Dr. Kulkarni, anybody can answer. So whenever one person, any young person, especially when we saw and heard about young patients getting a stroke of 28 years old, many times these young patients or young persons are on a move. So how should they recognize the signs that this is a stroke? I mean, how should a person recognize that this is a stroke and this requires urgent attention to go to a hospital? Because many times when we have seen these cases, they are just subtle signs. They are very minor signs on the body, and usually people tend to neglect these minor signs for few hours or 1 day or 2 days till they become serious. So some guidelines for the patients.
So as we discussed, B fast. So B is a balance, any acute change in the balance. E is eye symptoms, vision impairment, double vision, or homonymous hemianopia, or field defects. F is a face deviation, facial deviation, arm weakness, speech disturbances, either dysarthria, aphasia, or sensory aphasia, not able to understand what has been asked. And T is a time. So B fast is the simple thing we can emphasize over the community or population to identify the stroke. Once you know that you are in among this B fast, you should visit to the nearest neurologist or a physician. So to identify whether it was not a stroke. If it is not a stroke, then it's good. But if it is a stroke, you will lose the time. If you delay your diagnosis and treatment, you will lose the time of, and it may be a catastrophic event later on. So please, B fast. B fast is a B. B is a balance.
B is B. Achha, B for balance. Okay.
Acute onset change in balance. E is eye symptoms like vision loss, impaired in the vision, double vision, or visual field defects. That is
E. Huh.
F is a face, either facial deviation.
Okay.
Like you just ask the patient to smile, you are able to see that the patient has a facial deviation. F is face. A is an arm weakness, whether there is an upper limb weakness. Ask the patient to just hold in front of you, that just hold his arms. If it is able to hold for 10 seconds, that's okay. If he is not able to, that it is going down within the parity. S is a speech. There is a difficulty in speaking, dysarthria, difficulty in understanding what has been asked, like aphasia, and difficulty to pronounce or not able to convey. That's aphasia, motor aphasia. That is aphasia. That is speech. And any of these 5, you notice, just note the time and come immediately to the hospital.
So T stands for time. The last T stands for time. Okay. Okay. So that is a good mnemonic which you have told us.
So be fast. You have to be in the community or population that if you find be fast, immediately rush to the hospital.
And this applies to all, even non-hypertensive patients, persons, young individuals. No connection with hypertension or diabetes or any medical comorbidities.
Nothing connection with the any medical comorbidities. Nowadays, lifestyle has been so much changed. You will find that 25-year, 28-year male or female patient will get a stroke. So in two of my patients were less than 40 years. So stroke can occur anyone at any time at any place.
Yes.
So one of their question in chat box, 6-year-old female, diplopia, headache, MRI suggestive of cerebralitis, treated with steroids and antiviral. Day 2, the patient developed left hemiparesis. Repeat MRI was suggestive of basilar artery occlusion. What are the treatment options? Was the surgery treatment advisable in children? Treatment is given in Clexane and aspirin.
Go ahead, it is intervention question. You can always talk.
Okay. So till now the guidelines, as per guidelines we talk scientifically that 6 year is not a candidate to undergo thrombectomy, and the treatment in children especially has not been completely, I'll say that there are no pediatric guidelines straightforward for endovascular treatment. So whatever treatment was given, Clexane and aspirin should be a good choice. If the patient worsens, then beyond guidelines or beyond our conventional therapeutics, we can offer endovascular treatment for such patients. But that should be come from the patient party that they want a treatment option for this such condition.
What can cause anterior phase of 6 years?
Especially in 6 years, we generally find vasculitis or autoimmune illnesses or sometimes infective as well.
Congenital abnormal.
Yes, congenital, especially if the patient had a cardiac congenital anomalies, they may have cardioembolic strokes as well. But giving this such kind of history, it looks like either a vasculitis or autoimmune pathology.
Are we getting more patients due to COVID?
During the COVID time, the patients were increased because of thrombosity of this COVID. They say that there is COVID endothelial damage, and which increases the coagulopathy. So during that period, there was definitely rise in the stroke cases. But we just compared the COVID patients. We have not compared with the general population. Probably general population has not come to the hospital whenever they have a stroke or something. So there was, I think there was no study which has been compared with general population, the stroke has been increased or not. But definitely with the COVID endotheliopathy, the stroke were increased.
Is the incidence of stroke in pediatric patient, and is there any difference in presentation?
So there is no different presentation. Stroke is stroke, either in neonate, child, adult, geriatric. So brain has its own functions. So whatever brain tissue is damaged, that will show into your body.
Is there any differential diagnosis, any other which will cause this paresis?
Sorry, ma'am.
Any other differential diagnosis is for the paresis? Only stroke or anything else? Any other diagnosis?
Yes. Good question, ma'am. What it says, whenever it's acute, it should be acute, instantaneous, within minute. If it is paresis, this like hemiparesis or monoparesis, whatever it may be, it should be acute, instantaneous neurological deficit. It has to be vascular. There is no other differential. If it is like last 2 hours say over, slowly over, still it is a vascular, maybe even maximum time. If it is 1 day say slowly progressive or then it may be have to radiculopathy or a myelopathy like that. But if it is an acute neurological deficit, it has to be vascular.
It's our president, Dr. B.L. Deshmukh sir, to felicitate Dr. Lomesh Virul, who is physically present here. So thank you very much, sir.
Thank you very much for the opportunity.
Just wait.
आम्ही आडनाव नातेवाईक म्हणू शकतो तुम्ही, त्यांचं गाव वेगळं आहे. त्यांचं गाव वेगळं आहे.
आणि तुम्ही पण कोण नाहीये का? थँक्यू. जरा जरा एक आणि डायरी पण द्या त्यांच्या त्यात, डायरी आणि ते
कोविडमुळे डिले झालं माझं पण मेंबरशिप मागितली.
Thank you, Dr. Ramesh Birud, sir. We were it's very fortunate us for you to be present here physically. So thank you very much. I also thank our another eminent speakers, Dr. Rahul Kulkarni and Dr. Shripat Pujari, sir, for their excellent and thorough informative lectures and discussions, and followed by this discussion which our delegates, we cannot forget our delegates. They were very interactive and they had asked many questions also. So thank you all delegates also, and thanks our MMC observer, Dr. Raju Varyani, sir. I thank Bollinger Angiogram for their academic grant. And I thank DigiShield, Mr. Dipen Mehta, and technical expert Piyush Kale for their excellent oration. For this, our program, there was no problem. Only thing we had to shift and all. So, but it was very smooth. So, thank you very much. And with the permission of Dr. B.L. Deshmukh sir, our president, I declare that our this webinar is coming to end. Thank you, sir.
Thank you.
Thank you.
Thank you very much.
Thank you, sir. Thank you.
Thank you.
Thank you very much, ma'am. Thank you.
Thank you.